So good evening, ladies and gentlemen. PPH Skill and Drill workshop today for the societies of Dibrugarh, Jorhat, Guwahati, Gangtok, Silchar and Shillong. The topic is obstetric hemorrhage. PPH is the major cause of maternal mortality and morbidity worldwide. Any pregnant woman who will deliver is always at risk of PPH. The strategy is to stay prepared to handle these obstetric emergencies. So today we have all joined hands and of our busy schedule to share our knowledge and learn certain new things from everybody. So let us learn and acquire knowledge on this very essential topic of saving mothers. The coordinators being me, Dr. Maushami Das Ghosh and Dr. Babita Shukla from Gorakhpur. So lamp lighting, we shall start with lamp lighting. The chief organizer of today's webinar is Dr. Sadhna Gupta. She is the co-chair SAFOD NCD committee, FOXY representative to FOXY 2018 to 21, vice president FOXY 2016. May I request Madam to introduce our chief guest and guests of honor.
Thank you, Maushami. And first of all, a big thanks to all office bearers, President and Secretary of Dibrugarh, Jorhat, Guwahati, Gangtok, Silchar and Shillong Society, Dr. Pranay Phukkan, Dr. Jasmina Sharma, Dr. Amal Kumar Phukkan, Dr. Pranabika Mohanta, Dr. Nilakshi Phukkan, Dr. Deepti Goswami, Dr. Ritu Nag, Dr. Hafizur Rahman, Dr. Vandana Das, Dr. Tilanjana Datta, Dr. Limirul Millian and Dr. Juperika Ilagnon. Because of your effort and your coordination, we are together today on the very, very important mission of saving mothers everywhere. So gratitude to everyone who has joined us as a dignitary, as a faculty, and as a office bearer and as a august viewers. So it is a real great pleasure to be with the Northeast Society because that association is so very strong. And today, it is a great pleasure to have the chief guest, Dr. Gokul Das, guest of honor, Dr. Shashwati Sanyal, and guest of honor, Dr. Arun Madhav Barua. Because that association with these eminent people is not a 1 year or 1 day, it is almost a 20 to 25 years. Many opportunities, what I got first time, that was with the Gokulda and Dr. Arun. We had a very, very close association, and all the dignitaries, all the faculties, dignitaries have been the part of our all programs and conference. So that has been a wonderful and the journey, great journey. So it is a great pleasure to have Dr. Gokul Das, who is a father figure for all of us and for many, many all over the country, not only in the Northeast. He has been OSD Shri Mata Shankardev University of Health Sciences, Guwahati, Assam, founder, professor, and head of the department. TRIMS, Naragon, Arunachal Pradesh, professor and head of the department, Guwahati Medical College from 2012 to 2015. Officer in charge, Field Unit, Guwahati National Institute for Research in Human Reproduction. Has been the Vice President, FOXY in 2014 and the member of ICOG Governing Council. He has graced as the President, Guwahati Obs-Gynae Society, President, Association of OB-Gynae Society of Assam and Northeast, and delivered many, many lectures, oration, many publications to his credit. And he is what we say, he is the father figure and the source of a great inspiration and the guidance for all of us. So thank you very much, Dr. Gokuldas. You were so busy, but you've given your precious time to join the program, and request you to say a few words from your side.
Thank you, Dr. Sadhana, for your kind introduction. I don't know whether I deserve so much, but anyway, I do work for the welfare of our societies and welfare of Foxy. And you are also a great fighter for Foxy, and you have done so much of work for Foxy, specifically in the rural obstetric committee. You have done wonderful work. We are proud of you, and you have done great jobs. And our association is there for many years. And I hope that you really win this election this time and become president. With this, I just wish you all the best, and all the best to the webinar. Thank you. Namaskar.
Thank you, Gokulda, for your kind words and the invaluable, precious wishes. That means a lot to me and lot to us. Thank you very much. So now we have a very beloved friends, Dr. Shashwati and Dr. Arun as a guest of honor. Dr. Shashwati, a very simple and very knowledgeable personality. She has been professor, Department of OB-GYN, Guwahati Medical College, graced as a chairperson, Medical Education Committee from 2013 to 2015, Vice President ISOPAB 2020-22, and President ISOPAB Assam Chapter, past President of GOJS and member of Editorial Board, New India Journal of OB-GYN. She is also what you say, she is not only a very simple, very academician, very dedicated, graced so many organizations at various posts. She is a lover of like music and the song, very good singer she is, and a great companion to talk with. So welcome, Dr. Shashwati, and please, we wish to hear from you about the programs and its utility and whatever is from your heart. Please, dear Shashwati.
Good evening, everyone. And thank you, Sadhana, for putting me as a guest of honor. That tells us that you are getting old and you can be the guest of honor, you know. Yeah, that's good. And for the nice words, your nice words. And I really appreciate that you have chosen a topic which is postpartum hemorrhage. And Dr. Samatram just saying a few minutes before that in Assam, we have a very high maternal mortality. It is not 200, it was 195 in 2022, and probably it has gone down to little low also, 180, 185, like that. And one of the most important cause all of us know is hemorrhage, and you have rightly decided the topic is the hemorrhage. And you have brought the people who has really worked practically in this field, that is Dr. Samatram and Dr. Nalini Mishra, because I know how much work they have done for this. And for you, what I want to say is that every time, whatever you have worked for the maternal health. I think at this point of view, India, we want something to do for the maternal mortality, and especially the northeastern region, because we are putting our country in a place where the maternal mortality, we are bringing down, we're putting down, putting down the figures. That means it becomes a little still in the 2 figures, but I think if we can go to the below 100, then it becomes it will be good figure for India. And one of the important area of this maternal mortality, because I know how much you have done, you have written books on this, why mothers die, and you have done so many Saving Mothers conference. And we have learned a lot in these conferences, like Saving Mothers with newer guidelines for surviving sepsis guidelines. So many things you have incorporated in this subject, in this particular era. And I think as President of India at this moment, there should be someone who will look after into this maternal health part, because this is the one of the burning problem of our country. It is not the infertility, not that this is a part of it, definitely. But this particular maternal health, which is one of the causes, hypertension, another one is bleeding, and of course, sepsis is another. And I'm sure once, if you get that highest position, you will be able to do something solid on this particular topic, and thereby giving us the better outcome. And especially for the Northeast, I think something has to be done. Something solid thing has to be done for this Northeast. So we can really bring down this particular maternal mortality. And I really thankful for this particular position. You have called me as a guest of honor, and I wish you all the best in your endeavor, and we'll be very happy if you get the position. So all the best wishes from our side. Thank you so much.
Thank you, Dr. Shashwati. These words actually keep us motivating and keep us walking together. So you have been the integral part of this journey, and so that we remember and we look forward that we really go do something great, something we reach the unreached people, we take the geographical and the regional consideration, and likewise do the things and plan the things that work for every area. So thank you very much. So we have Dr. Arun Barua with us, and what is the like something very remarkable about Arun is that he is a very good endoscopic surgeon, a good infertility specialist, but I have found every time he has been like clinged to the like basic needs of the region, basic needs of the country, and he is always there with our all programs which are related to maternal and child health and the adolescent health. So that speaks volume of Dr. Arun Barua. He has been consultant Apollo Fertility Guwahati, Assam chairperson, NESAR, NEIG. He has been the key person to framing all these professional body in Northeast, President Dibrugarh OB-GYN Society. Senior Vice President IMA, Assam State Branch, Vice President East SOPSI, that is Society of Vaginal Surgeon of India, and active Rotarian for more than 25 years. So always a great pleasure to have Arun, and we have been participant of FOXI Managing Committee since a long time. And when I new, we will look forward like always to meet that what is going on. So Arun, how this journey becomes so worthwhile. So Arun, thank you very much for being with us, and we wish that we wish to request and hear from you for a few words. Dr. Arun? He was just here, I will see. Arun, Dr. Arun? He was just here. So I think, Moshmi, I think it's some connection problem because I just saw. Arun, are you here? So Moshmi, you can go ahead. I think some internet issue because I just saw him.
Yes, madam. Even he had joined. Now he's not. Yeah, we'll start the program. In between, we can when he joins, we can have his blessings. So moving to the first session, the keynote address by Dr. Sadhana Gupta. May I request the chairpersons, Dr. Pranay Pukhan sir and Dr. Manjima Baisham Ganguly madam to chair the session. Previous slide, please. Dr. Pranay Pukhan sir is the professor and HOD of Sanghaini Lakhimpur Medical College, teacher of undergraduate and postgraduate for 32 years. University examiner, ICOG visiting professor, AOFOG Young Gynecologist Awardee, President of Dibrugarh Obstetrics Society since 2022, Honorary Secretary of Dibrugarh Menopause Society, and lot of publications to his credit. Next, the other chairperson, Dr. Manjima Baisham Ganguly madam. She is the Vice President of Guwahati Society, former President of IMA Dispur, former Honorary Secretary, National MPH member of the IMA, life member of IMA. Madam, may I request you to please introduce Sadhana madam and start the session. Manjima madam.
It's not.
We can hear you, madam. We can hear you.
Yeah. Actually, there's some problem with my video, so I cannot resolve this. Anyway, I will introduce, if you can hear me, it's all right. I'll introduce Dr. Sadhana Gupta. She is an MBBS gold medalist, and MS also she is a gold medalist. She is co-chair Suffolk NCD committee. She is FOXI representative to Suffolk 2018 to 21. She is the vice president of FOXI 2016. And she is ICOG governing council member with Best Governing Council Award in 2021. And she is the corresponding national editor and peer reviewer, Junior Journal of OBGYN and Journal of SAFOG. And she is FOXY past chairperson, FOXY Safe Motherhood Committee with FOXY Dr. Mehrood Ara Hansotia Award for Best Committee Activity. Thrice country representative to the WHO on key women health issues. And she has won the Korean Award winner 3 times for Best Scientific Research Paper. She has got the AICOG Best Research Paper 4 times. And she's the author of the book Caesarean Delivery, Vaginal Delivery, and a comprehensive textbook of OB/GYN. And she is the editor of the Safe Motherhood Bulletin, ICOG Campus and FOXY Focus, and Book of Safe Motherhood Initiative. She has been awarded 3 times FOXY Dr. D.C. Datta Prize for Best FOXY Publication and Manual. She is the awardee of Chancellors and Dr. Nawal Kishore Gold Medal for Best MBBS and Postgraduate Student. She is the key organizers of many national and international conferences like the Adolescent Congress 2002, ICOG Conference on Maternal Mortality, North Zone Yuva FOXY, Saving Mothers, Avigyan FOXY FIGO Support 2021, Prevention of Stillbirth 2021, and has delivered keynote address and oration in national and international forums, namely Dr. June Thapa Oration at Nepal, and also the Kutti Memorial Oration and Professor Urmila Gupta Memorial Oration. And she has been honored at many national and international forums for exemplary work done to reduce the maternal mortality, community service, and women empowerment. And she has also received the FOXY Durusha Award for Distinguished Community Service. And she has been the awardee of FOXY Super Achiever Award, Pride of FOXY Award 2019, FOXY Star Award 2016, recipient Dr. N.A. and Saleja Pandit Award for Women Empowerment. And she has also got the Economic Times Award for services in COVID times. She is the director and the senior consultant OBGYN, Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. She is also the FOXY presidential candidate, election year 2023. Over to you now, ma'am.
Thank you, Dr. Manjima, for a very kind and generous introduction. So once again, gratitude to all office bearers of the societies. And that's why we are together. And I will be dealing with the first step. When it is done right way, then actually the need of the very high second order and the third order management remains low. So that is very important. And this is what a great journey we had in the so many conference, and like being at North is something. It is beautiful, breathtaking landscape and the breathtaking, beautiful people and dance and music, lover of the culture and art. And there is so much to give and receive from the Northeast. So for postpartum hemorrhage, I bring greetings from the land of Buddha, and that is, we can never obtain peace in the outer world until we make peace with ourselves. So with postpartum hemorrhage, it is so very important. And we all know what Dr. Shashwati was saying, or Dr. Gokul, that actually PPH is contributing to major share of maternal criticality and maternal mortality. Around 35 to 50% of the death occurs due to postpartum hemorrhage. And what is the clinician perspective, that when we choose obstetrics as our subject, as our livelihood, as our profession, we are bound to get it in around 2 to 10% of all deliveries. And out of this 1 by 10, 1,000 can be massive and life-threatening. Things does not end with the PPH. The woman can have a long-term severe morbidity like severe anemia, secondary infertility, Asherman, and many measures what we do during tackling PPH like obstetrical hysterectomy, massive blood transfusion, all are categorized in the near miss or the severe acute maternal mortality. So it is a lifetime thing for the obstetrician. It is a lifetime scar for the woman also. So in India, the 35 to 50% of maternal death due to PPH, and why it is so very important to talk and re-talk, converse and reconverse, and finding new ways to deal with, because that is the postpartum hemorrhage where we can lose the patient within short span of 2 hours. It tests your leadership, it tests your readiness, it tests your functioning of health system, it tests your staff also, because it comes to like sometime only like a thunderbolt, unpredictable. So that's why we have to need talk again and again. What are the complexity of India, that we have all our age-old issues, like still we are having every second woman is anemic, we have still 3 delays, we have still a lack of sound referral system, that is a respectful, organized referral, but we have all the new things what the developed world is facing. So we are having lot of mothers in elderly age with comorbidities, with obesity, with myoma, with coagulopathy. So we have to lead. Our textbook does not tell about them, and the totally change of obstetrical demography in a quite big number, like around 10 to 15% of the obstetrical population, the obstetrician have to be ready with the new knowledge and the new armamentarium. So that is when we save the patient with PPH, it enhances our self-esteem, it enhances our belief in it, ourselves. When we lose the patient or PPH, or the patient is critically ill, having a long-term like complication, it is a demoralizing effect on the leading obstetrician and hospital team. Many people wish to leave the obstetrical practice, they are become depressed. So many issues are there. So that's why we have to go through the optimal management, because if we do suboptimal management, then it will threaten not only well-being of mother, but also neonate family and obstetrician. And it has always and always potential medical, legal, media, and social issue. So with all these, when we have today the political will, now this is the time, like we can say around 20 years ago, there was no political will, but we are fortunate to have a strong positive will at this moment. And as a obstetrician, it is our duty that the optimum care is not delayed when the patient has come to us in our health facility. So coming to this thing, can we prevent postpartum hemorrhage? That is very, very important. So the things does not start only into the labor room or in the cesarean operation theater. It starts in our OPD. We have to identify the risk factor. So that is the very, very important factor, that we take out the history that she had PPH in previous delivery, any placenta abruptio, what is location of placenta, any predisposing factor like preeclampsia, grand malady, and the pre-existing bleeding disorder. But after you have identified the risk factor, what next? So this is very, very important, that patient might go to anywhere. She may go to the primary health center, any very small place. So once you identify, you say the risk factor, flash on antenatal card, write with the red pen or something, and counsel the family that this patient can have the PPH, and you have to be ready with the possibility of donor, and you have to ready with your birth preparedness plan. After this identification of risk factor and the flashing and doing the thing, like turning knowledge into action, active management of third stage of labor is the thing which is the right of every birthing woman. And we have come a long way. I have spent around 7 to 8 years in Foxy about the right refrigeration of oxytocin, and implementing that we have the standard practice of active management of third stage of labor. And the most important arm is the oxytocic agent within 1 minute of birth of the baby. Why it is so very important? Because it prevents PPH, it reduces severe PPH, it reduces need of blood transfusion, decreased risk of anemia, and the other uterotonic drugs. So the safest thing is the oxytocin. If the IV line is not there, then 10 unit intramuscular or into the fluid. And beauty of oxytocin is that there is no contraindication for use of this drug, and it has a minimal effect on the hemodynamic stability of the patient. So it doesn't affect vitals. A lot of misoprostol we are using, but important thing which I wish to communicate, that it is always a second choice drug. It is not a first choice drug when it is a community setting, and it is also sensitive to moisture in the area of high humidity, and it has a sometimes like a fever or the pyrexia, and we have to be ready with it. So all professional body says that the universal active management of third stage of labor, and now we have the carbitocin, a long wait is over, because just now Dr. Shashwati was saying that Guwahati also we have the temperature of 38, 39 in summers. So the oxytocin, when it is not kept in cool chain, it reduces its efficacy, and when we need most oxytocin, it is not working. So carbitocin, especially the room stable carbitocin, has come to our rescue for a very, very important armamentarium for the active management of third stage of labor. It has a very, very strong affinity to oxytocin receptor, and a very good choice for active management of third stage of labor in elective cesarean, and also in vaginal delivery. India contributed a lot into the champion trial. So we have our own racial study that it is effective, and 100 microgram 1 ml should be administered as a single dose. So there is no role of double dose, and it is no role for the induction of labor. So two things are very important. Why it is different from oxytocin, that never to be used before delivery, and it is only single use. It is not to be repeated like oxytocin. Second important beauty of carbitocin is that eliminates requirement for infusion. So patient who have the preeclampsia, who have the anemia, when we used to put on the long oxytocin 3 or 4, 10, 10, 5, then there was always risk of hyponatremia, pulmonary edema, fluid overload, and carbitocin actually avoids that fluid overload with the continued use of oxytocin. But like what it can be turned into the really delivery for the woman when we have the availability of this agent, when we have a aware of cold chain provision, we know what is happening in our pharmacy, what is happening in retail store. Our birth attendant, every nurse, every junior doctor know that it should be preloaded before delivery of the baby, and we have to always audit that every woman is getting or not the active management of third stage of labor. Now the late cord clamping has come, which is an additional benefit to Bobby, and a very, very important thing is a controlled contraction. WHO and all professional body puts a bar that only when you have the experienced birth attendant, be it a nurse, be it a junior doctor, only then you do the control contraction, because it can result into the milder or the severe form of the inversion. Finally, the more you sweat in peace, the less you bled in the ward, but you are found to get the PPH anytime. It is unpredictable, so we have to be ready with our drill. And why do mothers die? Because we don't correct hypovolemia, and we have a delay in a cause analysis. So golden hour is birth hour of gold. What we have to look into golden hour, that is the tone and height of uterus, reading PV, pulse, BP, what is the level of alertness. But important thing is, as a obstetrician, we know everything, but how it can be turned into the practice only when in our labor room we have the all good monitors and a good trained staff. Because and the third thing is that patient after delivery not to be shifted to the postnatal ward unless the 2 hours have been passed, be it a low risk or the high risk. So this is very important, that how we can turn knowledge into the something which can make a difference with the implementation and the availability of expertise and equipment. We all know what is primary and the secondary PPH, but important thing is we know 100 cause for the PPH, but when you are called to the case situation, you make a quick 360-degree review. And while we are resuscitating your brain, our brain should be working that what is the cause of PPH in this particular patient. Tone tissue trauma thrombin is the thing which is the basics of the postpartum hemorrhage. Important thing is that in cause analysis, in 360-degree review, we must be knowing what was the quick obstetrical history, what was the risk factor, whether she was having any prolonged use of oxytocin, chorioamnitis, or she is having fibroid, or she is having polyhydramnios, she has the difficult delivery, oversized baby, so that you have a clear cause analysis that this 1 or 2 cause might be the cause of PPH in this particular patient. So if placenta is there, you have to look for the placental pathology. Today, now when every 3rd or 4th patient is on aspirin, so much relevant is high use of heparin. The anticoagulant drug is also come as an important cause of the postpartum hemorrhage, and the careful protocol when you have to stop aspirin, when you have to stop heparin, that is also very important, and precedent pathology for the DIC. Of course, the tone is the 70%, but we now have a lot of trauma retained product, especially with the the PPROM, the early IVF pregnancy, multi-fetal pregnancy, when we have a lot of placental cause for the postpartum hemorrhage and the coagulopathy. In one patient, you can have more than 2 or 3 causes like PROM, which causes septic, which causes atony, use of tocolytic, and everything combines to the PPH. Why we miss the diagnosis in golden hour? Because nature has been very kind. Nature gives the hypervolemia to pregnant women so that she can bear loss, natural blood loss after the delivery. So a normotensive woman can be hypertensive and hypertensive woman can be normotensive, and that's why there is no initial change in blood pressure, and that's why we miss the diagnosis in the golden hour. So a good careful estimation of blood loss, a good instruction to labor room staff that if you see that there are 5 soak pads, if you see there is a continuous trickle, and Nalini is going to tell about the like a Chhattisgarh drape, we have the Devdas bag, or you see woman is not looking good, like what is it, she does not look good, she is having nausea, vomiting, confused, this is time to call the senior person on the field, senior person to the labor room. Whom to call for help, so it should not be random calling to walls. We should know every time that whom to be called, which anesthetist, which senior nurse, which friend, which ward boy and dice, which theater staff, and call to blood bank person. So we always say call for help, but it must be organized help, and we have to make friends beforehand when we are dealing with any emergency. Always look for the vital cause analysis, what is the amount of bleeding, and we all know pulse, BP, tissue perfusion indicator, urinary output, and the capillary refill. So it is not something rocket science. It is just a quick evaluation that what is happening. You can see what is the urine output, that the patient capillary refilling is delayed or normal, and what is going on with her pulse and blood pressure. Shock index is the simplest thing what we can do, that is heart rate and systolic blood pressure. And if it is less than 1, you have a breathing space. But if it is more than 1, you have to be ready with the aggressive measure. Golden classical teaching rule of 30, we all know. And after the assessment and the cause analysis, what we are doing, that for resuscitation, what we must have: oxygen cylinder, airway, drugs, emergency tray for PPH chart, and all the contact number. So the basic EMOC, replace fluid, arrest bleeding, send blood for group and cross match, catheterize, alert consultation, consultant obstetrician on call, record event and communicate. Never take even a minor PPH that it does not need to be communicated to the patient's relative, because you never know which patient is going to turn into what way. So that communication and building confidence with our patient's relative is very, very important, because this is the condition where we need the total cooperation of the patient relative. So this is very, very important. And when you think that it is around 1000 ml with the quick loss, we have to be ready with all the food protocol of measure for the resuscitation, monitoring, and arrest of bleeding. Give oxygen at 10 to 15 liter, irrespective of oxygen saturation. Always apply 2 IV access. Maybe it might not be needed, but be proactive. PP is the thing where we have to be proactive. A little over treatment does not harm you, but under treatment may prove you very, very costly. So green or the gray cannula, no pink cannula into the labor room, 2 IV line, keep the patient warm, flat, always catheterize, and always send the investigation for the coagulation profile for liver function and the renal function test. We must be knowing, especially in placenta accreta spectrum, aortic compression and aortic clamp has come in a big way, because they are the temporizing measure when we can have a breathing space because of aortic, how we have to stand on the stool on the left side. We have to have our head straight, thumb outside. And this technique we have to learn, because sometimes we have a real life-threatening sudden postpartum hemorrhage. So this is all resuscite, investigate, always send. So what is there that in our PPH box? It is not only the drugs. We must have a 3 plain vial, 3 citrated vial, and 3 EDTA vial, so that we can send all the necessary investigation when we deal with the PPH. So it is a PPH care bundle. We have come, we know that actually what works, what the combination of thing works, and we must be knowing that the good crystalloid uterotonic drug, tranexamic acid, and the uterine massage are the first line measure. And when you see that it is a 1 liter blood loss, then you give around 2.5 to 3 liter of the crystalloid, that is ringer lactate or normal saline. So it is a crystalloid. Many times anesthetists or sometimes say, even nurses, that start with Hemaxil. Blood pressure is going down, so start with Hemaxil. I really wish to say that you must be very clear in instructing the initial the volume perfusion, volume replacement is with the crystalloid. After you have given around 3 liter or 2.5 liter of crystalloid and blood is not ready, in between that time, the colloid infusion can be considered, because colloid remains in intravascularly. They have the more chance that the patient can land up into pulmonary edema and they can interact with the coagulation test. So it is a ringer lactate normal saline 3 times up to the estimated blood loss, and always the cause analysis has to be there. So ask right question. If placenta delivered, see it is if placenta is complete or not. What you have to do, always be very strict in it that the placenta, neither patient to be shifted into the postnatal ward, nor the patient to be thrown in the biomedical waste disposal or somewhere, so that if you want to recheck, placenta is not there. Did bleeding start immediately after delivery of the baby? Maybe the trauma is there, placenta not delivered, mobilize for MRP, and if it is not complete, mobilize for the exploration. The art of massage, that is gentle rubbing, the like a round compression, round movement, the evacuation of blood clot from the vagina, we have to retain this gentle art. And we have all these drugs as armamentarium, oxytocin, carbetocin, methyl ergometrin, misoprostol, and PGF2 alpha, which are the oxytocin drug. We must know the contraindication of each drug, and we must optimize the use of each drug. It is not so that you give only 10 unit oxytocin or a 1 or 2 ampule of methyl ergometrin. So this is very important. You can give 4 ampule of methyl ergometrin at the interval of 15 minutes, 8 ampule of the prostaglandin up to the 2 gram. You have to be careful that you ensure adequate storage, and you can give the drug consequentially. If you have given carbetocin as a active management of 3rd stage of labor, then the oxytocin is not going to be effective. Then you have to use the methyl ergometrin, misoprostol, and the PGF2 alpha, and the IV fluid resuscitation to be continued. So important thing is that optimize the use of medical management. Now we have a very, very good drug. Don't be the underusing drug. Always take the careful precaution that what is the contraindication of drug, like in anemia, in heart disease, in PIH, we don't want to give the methyl ergometrin, and in prostaglandin, we don't want to give in the heart block or in the asthma. So that is very important. Now, after women trial, the tranexamic acid has come to our one add-on armamentarium, and in my long journey in Foxy, actually we were listening when the first few drugs came after the women trial. In the FIGO it was presented, in AICOG it was presented, and now we know that the tranexamic acid, early use of tranexamic acid, prophylactic use of tranexamic acid can be useful in preventing the severe PPH, preventing the maternal mortality, and it is recommended. Important thing with tranexamic acid that it should be given in the early stage. After 3 hours, it is not going to have any effect. So give it first if you counter PPH. After 1 hour, you can give, but after 3 hours, it is not going to help. A very, very important caution point is that tranexamic acid ampule and the bupivacaine ampule look same. And there has been a good paper from the International Anesthetic Association, like person that the potential and accidental fatal intrathecal delivery of tranexamic acid. In our own Indian Medical Council, there are cases pending when we have the mortality and the criticality after intrathecal administration of tranexamic acid because they look same. So one magnifying glass in the operation theater is a must. These are the non-technical issues, but actually it really saves you with the human error, what we have a lot of work, and when we have a lot of emergencies, anesthetists, everyone can add, and we have to work on the minimizing that error. When to look for the blood transfusion? If hemoglobin is less than 7, and you must have a simple instrument, that is the HemoQ, so that you know if it is 6, 7, you have to be aggressive. Less than 6, you have to be very, very aggressive. If you have around 8, 9, you have a breathing space. So that is the ongoing hemorrhage. What is the pre-antecedent obstacle condition that makes you that which patient require the blood component, what blood component. If the patient have the DIC, abruptio, preeclampsia, HELP syndrome, then the patient can have the coagulopathy, that is DIC. We talk of now rotational thromboelastometry, which actually spends a crores, and it is not available. I think not even a single or 1 or 2 labor room. It may be in the ICU or the like a different sort of OT where the cardiac or the ortho work is going on. So we have to be knowing, we have to retain the simple thing, that is bedside clot test. And we have a wonderful paper in our own Nalini Mishra that it so much correlates with the fibrinogen level, that what is the clotting time and what is the clot retraction time. Massive transfusion protocol, just I wish to say that it starts only after 2, 3 or 4 unit of PRBC. So when we say 1:1:1, it is not so right from the very beginning, except in situation of the coagulopathy. So it starts after 3 or 4 unit of PRBC. We want to achieve a good hemoglobin around 8, platelet count around 75 lakh, and a good coagulation profile. We have to be ready with the PPH trolley, PPH trays. Always record, event, communicate. It is a potential medical legal issue. Join Manyata, that your training, your nurses are trained, you join Lakshya, you join Manyata, and always the treatment of the cause, that is if it is retained placenta, you have to mobilize MRP, inversion, you have to correct, and laceration, you have to treat. Conversion, bimanual uterine compression, important thing, as our Dhamartha is going to talk about it. And when you have to take hard decision, you have to take, because obstetrician is a something hardcore branch. So good exploration, if it is trauma, with the good anesthesia, good lighting, good assistant, good technique, and like dealing with the difficult situation. Dr. Pally has evolved with a beautiful instrument. We have just 7 days before, we had a wonderful dialogue with Dr. Pally, and how he evolved these things, that just a passion to save mothers in all settings. Like we have to recognize our own thing, what are resources, where our patient resides. So transvaginal uterine artery clamp, a wonderful result, a wonderful paper documentation. Nalini is going to deal with the tympanoid, and whenever the MRP is needed, take decision in right time, because Ian Donald rightly says the difficult part about MRP is the decision to undertake it. Don't go in delaying, just it will take some time, let's see, and suddenly you find the sepsis and the shock. So coagulopathy, we have to be aware, it is up emerging cause because of antiphospholipids, SLE, viral infection. In our country, we have a lot of infection, dengue, so the coagulopathy can come into the different way. Always take right decision when you have to open up. Patient is totally unstable. She is bleeding like bleeding, pouring. The uterus is flabby. You cannot find uterus. This is time to take to the OT and do all the things which is needed. And that's why we need always the skill drill, clear decision making, and confidence making. Important thing is that the all academic thing or skill thing, which takes the confidence from our average OB-GYN, there is the issue that when we make them, scolding them, punishing them, talking ill about them, and that makes the confidence of the doctor as well as their team. So our all academic webinars, we have to be careful, very, very careful, that we always give them the confidence that they can deal with it, because saving lives is very, like our profession, it is our passion, and the drastic situation need aggressive measure. We have to set the protocol, good decision, team making, friends making, and if the surgery or hysterectomy is needed, you do in the right time. So if you can fill the unforgiving minute with 60 seconds worth of distance, run. And that is the PPH. So I seek everybody's blessing, wishes, and good, like full-hearted support for my upcoming election. We can do a lot together. I've been the part of the Sambhu project in the initial stage, who was working in the tea garden data. I think in one of the good conference, I was there with the like Shashwati, that what is meant by the quality care. So we can have to regionalize the issue. We have to take the expertise and experience from every part of country, and only then we can have our head high in front of our people at international forum. So this is the way ahead. And so this is my vision, basic vision for the women healthcare. And I seek everybody's support for my forthcoming election. Thank you very much for the patient listening.
May I request our chairperson, Dr. Pranay Pukan sir, for his comments.
Can you hear me?
Yes, sir. Yes, sir. Please.
Yeah. So I'm very late because I was late because of, that's the same problem. One of my colleague, he was operating a patient and he has suddenly, the patient has PPH. I was operating in another theater, laparoscopy. So I had to run when he called me. Exactly the same thing that Dr. Sarna has just described, we had to do. So it's such a serious problem, and she has nicely finished everything in a very short, time. It's a big subject. Specifically, the management of PPH in 2022, probably FIGO has given some recommendations. She has told everything. She has told about the carboxyl really, which is a very beautiful drug, and then tranexamic also, it should be given. It is necessary for in our operation theaters to be carefully, should select the vials and all. We should always keep our anesthesiologists at least ready, or the other people should be ready for all these complications. And then recently they are saying that the shock management, when there is a shock because of postpartum hemorrhage, it can be managed by two ways. One is the conventional ways, aggressive treatment that Dr. Sadhana has told, the fluid, normal saline and all. But there are some disadvantages when they give normal saline, and then we want to take the blood pressure high. In those cases, there's some complications like the normal saline aggressive therapy can sometimes lead to, that pressure can lead to some clotting mechanisms can be disturbed. There may be coagulopathy, and that can also lead to some pulmonary edema, and all these things until the blood is ready. So this aggressive therapy now can be replaced by one new technique that they are saying. It is called permissible hypotensive therapy. Here only ringaroxetine is given, and systolic blood pressure is maintained around 80, and mean arterial blood pressure should be around 40 to 50. So by doing that, we can get rid of these complications until the blood is ready. And blood transfusion, rightly he has said, so we have to go for whole blood, but first we have to maintain the 1:1:1 ratio. That is really essential to get rid of the other all problems. So it's a very big subject. And then Dr. Sadhana, I welcome you all to the Northeast, our doctors, as well as our best wishes for your coming elections. And we are always with you. Thank you very much.
Thank you very much, Dr. Pranay. Yeah. Thank you very much. And just like that is the is something gray area about a permissible hypoperfusion, because that is that the woman is fluid responsive or not, and inferior vena cava, and you do the leg raising and see that the inferior vena cava size is there or not. So for many settings, like in septic shock and many things, it is workable. But for PPH, actually, we still have something question about it, that actually when the patient is bleeding, we have to be optimal with the good IV replacement. So it is something where I think we have to gain the experience from all the experts in the coming time. So thank you very much for your word of it.
Thank you.
Madam Dr. Manjima Baisha Ganguly, madam, your comments, please. Manjima, madam.
Yeah, can you hear me? Yeah, it was a very informative lecture by Dr. Sadhana Gupta, and we were very much thrilled to see the way she has delivered it. And she has given many relevant points regarding the management of PPH, and we should follow these steps. And I think the younger students and the PGs will have benefited much from her lecture if they have listened to it. So thank you so much, Dr. Sadhana Gupta.
Thank you, Dr. Manjima.
So thank you, our chairpersons, Dr. Pranay Pukan sir and Dr. Manjima Vaishya Ganguly madam. And so moving on to the session 2, we have skill demonstration on uterine balloon tamponade by the expert Dr. Nalini Mishra. The chairperson is Dr. Pranay Nath sir. Dr. Pranay Nath is the professor and HOD Obs and Gynae in Silchar Medical College. He is the organizing secretary of NEOSCON 2005, former president of Silchar Obs Gynae Society, and lot of academic contributions and publications in undergraduate as well as in postgraduate forum. Sir, please introduce Nalini madam and start the session.
Thank you very much for making me a part in this particular program. Because as it's been mentioned all the time, with the people at Northeast, we do face in reality what is the problem of PPH in our place. However, let me introduce Dr. Nalini. Yeah, she is having a lot of work in the field of the bleeding in particular. I have seen what I could see. She is the dean and professor Allen Medical College and also in super specialty hospital Bhopal. What is very important and attractive for everyone, she is doing a lot of innovative works in the form of a balloon, in the form of a drape. This is to in fact manage a patient in labor and bleeding. So in innovative work, whatever form it is, she is also reporting it to the FIGO, to SFOG. So in every place, I consider that she could make an imprint of her work. And what is very important, she is having the conferences update as a faculty in many of the conferences, more than 150. I consider it is much more is possible. Publication more than 50. What is more important, Madam Nalini, your citation is more than 150. It is really, really wonderful. And I am sure your presentation is also will be very meaningful as like before. And I like to inform the house, the platform. Here it is a cyclone going on outside. I do not know how long my net will help me, but the program is wonderful going on. With all my good wishes, I am there as long as my net permits. So thank you very much. Welcome, Dr. Nalini, and the screen is yours.
Hello. Can you hear me?
Yeah.
Hello?
Yeah.
Hello. Okay.
We can hear.
Thank you, Nath sir. Thank you, Dr. Nath, for such a generous introduction. And thank you, Sadhana ma'am and Maushami. You have been doing excellent. Conducting very nicely. You are conducting the program. So I thank Sadhana madam. No words are enough. And I just simply wish that she becomes the next president of Foxy, so that she keeps on doing the same good work for all the women of our country. So I think without wasting any more time, we should start the video, Maushami. I am Dr. Nalini Mishra from Bhopal. Chhattisgarh drape is an innovative low-cost drape which is prepared of plastic apron. This is used for visual estimation of blood loss after vaginal delivery. You can prepare it at the point of care. What we need is a plastic apron. This is very easy to make, use, and can be disposed in the yellow bag. And it detects PPH in real time. It costs around 15 rupees each. The vertically folded plastic apron is taken, and the lower edge of this vertically doubled plastic apron is sealed with the help of a plastic sealing device. It takes only few seconds, and the completion is denoted by the sound of a beep. This lower portion of the plastic apron, which is now sealed, is unfolded in a manner that it forms a cone, as you can see. This cone is used and is denoted at 10.5, 12 and 15 centimeters with the help of a plastic scale, and it denotes the volumes of 350 ml, 500 ml and 1 liter. The neck piece of the CG, this drape is cut, or the plastic apron is cut. Now the cone of this CG drape is folded under the woman who is in the first stage or early second stage of the labor, and the belt which we use to tie the apron on our back is tied in the front of the abdomen of the woman. This forms the lower belt. Now the neck piece which we have cut, the two ends will serve as the upper belt, so that all the blood is siphoned into the cone and does not spill here and there. After the baby has delivered and amniotic fluid has drained out, we ask the woman to lift her buttocks a little and we unfold the cone like this. Then the whole blood after the delivery of the baby is collected in this cone or pouch and can be measured in real time. You can dispose this CG drape in the yellow bag along with the placenta and other tissues. If the woman is having a tonic PPH, not responding to medical management, we have to go for the second bundle, and intrauterine balloon tamponade is an important component. And when do we use the UBT? When the obstetric shock index has crossed 1 but is still less than 1.5 is the ideal time to use this. So I'll be describing two devices. One is Chhattisgarh balloon and another is easy balloon. Chhattisgarh balloon has a central drainage port, whereas easy balloon is more of a conventional condom balloon tamponade. So how do we make Chhattisgarh balloon? We need a Foley's catheter with a bigger French, condom, scissors, 2 syringes of 10 or 20 ml each, saline, and we prepare it in all the aseptic precaution from the steps A to F, A, B, C, D, E, F. So A is for air. Remember, A for air. So introduce air with the help of a syringe and inflate the bulb of the Foley's catheter, and then it is wound round over another finger so that the shaft is out of the way, because we are now perforating the bulb of the Foley's catheter, and this perforation is extended all around the circumference of the Foley's catheter. So now we have resected the bulb and the cut ends are everted up and down. This will expose the hole on the shaft of the catheter in the area of the bulb. Now we are moving to B. B is to make the bulb. So we are replacing the bulb of the Foley's catheter with a bigger bulb which is prepared of the condom. So roll the condom over the catheter. Now we come the C. So C is cutting 2 rings from the urinary drainage port. At the end of the urinary drainage port, prepare 2 rings just like rubber bands. Now this was C, and D is double application of these rings. So first of these ring is applied in the upper portion of the exposed area of the bulb, so in the neck. Then the second ring is taken and it is applied in the lower portion of the condom, 1.5 to 2 centimeters away from the rim of the condom. So this is double application of the ring. Now comes the E. So we have to excise the tip of the condom and tip of the catheter together at the level of middle of the urinary drainage hole. This will create a hole at the top. This is then in this CG balloon is then dipped into the betadine solution for at least 3 minutes. We cut a bottle of normal saline like this and expose. You see it in the CG drip, the blood loss is more than 1 liter. OSI must be more than 1. Expose the cervix with the help of 2 big speculums. Always keep big speculums in your PPH tray. Then catch hold of the anterior and the posterior lips of the cervix and take out the Chhattisgarh balloon from betadine. Keep it in between your 2 fingers and insert inside the uterine cavity. It goes very easily till the rim is reaches the level of the upper portion of the os. After that, we are going to pack the vagina with a big dressing pad or an autoclaved pad. This is done, and after that the urinary drainage port will be connected with the urosec, because this will be draining the blood which is going inside. You can see the blood which is inside the uterine cavity is now can be seen in the tubing of the urosec. Since we have replaced the bulb of the Foley's with a bigger bulb made of condom, so we have to inflate it through the bulb inflation port. So take the syringes alternatingly, and one person fills the syringe, another person inflates the bulb through the bulb inflation port, and this is done till either the resistance is felt or the column in the tubing stops moving. So that is the hemostasis. So once the hemostasis is achieved, we can now proceed further. You see the nicely inflated bulb inside. Then we catheterize the bladder, mark the margins of the uterus, and then put her on oxytocin drip, give her antibiotic. Of course, you can prepare the CG balloon. There are many advantages. The bleeding can be assessed through the drainage port connected to the collection bag, and you can pack the vagina. So it takes care of the expulsion of the UBT, which is the biggest problem in conventional condom balloon tamponade. You can always prepare CG balloon in advance and get it ETO'd and then keep it ready for use. In case you are forgetting these steps or there is no one and suddenly the emergency has struck, so anybody can make a very easy variety of condom balloon tamponade, and that is easy balloon. That is really easiest to make. There is nothing much in that. It's more of a conventional condom balloon tamponade. So again, take any size of Foley's catheter, prepare 2 rings. This 1 millimeter ring is cut from the end of the urinary drainage port. Then the condom is rolled over the Foley's catheter, the tip of the Foley's being in the tip of the condom. Then take 1 ring and apply it 1.5 to 2 centimeters away from the rim of the condom. So this 1 ring is applied twice, only do it twice. So this is done. So it's how easy it is to make the easy balloon. After that, you dip the UBT which we have prepared in the betadine, expose the cervix with the help of 2 big speculums, and catch hold of the anterior and the posterior lip of the cervix with the help of 2 sponge holding forceps. Now take out the easy balloon from the betadine and then insert it inside the uterine cavity. It again goes easily till the rim of the condom is visible in the upper portion of the internal os. This must go as at least this far in, and we have to visualize the bleeding at the level of the internal os. Now how do we inflate it? We have to inflate it through the urinary drainage port by connecting an IV set to it and IV normal saline. So the saline goes through the catheter into the bulb of the which we have prepared by inserting the condom over the catheter. So the saline goes easily and you have to do it till the bleeding stops. Once the bleeding stops, now we have to occlude the distal portion of the Foley's catheter. So that is done by folding it and applying the second ring 3 times over the folded lower end of the Foley's catheter. Remember it, we have to do it 3 times so that the fluid doesn't come out and the UBT is not deflated before time. Once this is done, check the bleeding again, it is stopped, and then take out the speculum and pack the vagina with a big, either a big sponge holding, big dressing pad or a big autoclave perineal pad. So then mark the margins. When we have to deflate it, just pull out the 2 ends of the Foley's catheter. The ring will just get away, and this can be done 6 to 24 hours later. When we talk of CG drape, CG balloon or easy balloon, These are all the local innovations and can be prepared at the point of care. There is nothing commercial about it. I'm proud to be Indian. Thank you so much.
Nalini madam, do you have any
Yes.
anything else?
Hello?
Yes, madam.
Ah.
After the excellent video demonstration, do you have any message?
Yes, the only thing I want to say is these are all low cost innovation. It costs nothing and hardly anything can be prepared from the things which are available in the labor room itself. And CG tape costs only 15 rupees and CG balloon or easy balloon costs only around 50 to 100 rupees. The use of UBT is evidence based. All the guidelines of the world, they and you don't need any electricity, nothing you need. So, and easy balloon can be prepared by even staff nurses. So there's nothing commercial about it. So please, wherever there is a very low resource setting, and even if you have to refer the patient, you put her on IV line and oxygen and put one UBT and pack the vagina, and then only you transfer, because even you think it is not controlling the bleeding, but even then it limits the bleeding. So even if you have to shift the patient from labor room to OT, at least put a balloon tamponade in the uterus and then you shift her to OT. So many times it happens that you don't need to do anything in the OT. You reach there and the bleeding has stopped. Sometimes it may take few minutes, up to 5 minutes sometimes, but otherwise generally it is resistant, and you start feeling the resistance. In the CG balloon, we inflated through the bulb inflation port because we have replaced the bulb of the Foley's with a bigger bulb. So we have to inflate through the bulb inflation port, and that has to be done actively. So we do it by syringes, just like we do in the Foley's catheter when we put it in the urinary bladder. And in the easy balloon, because we have not replaced the bulb, so we just simply inflated with the saline connected with an IV set. So whenever the fluid stops, fluid goes slow, or you feel resistance, then you check the bleeding, and it's very effective. And there is so much literature, so many, all the bodies have recommended the use of UBT, even the WHO technical committee in the second bundle. So thank you, Marshmi. Thank you, Sadhana ma'am, and thank you, my chairperson. He has been so generous, and thank you, Nath sir.
Requesting Pranay Nath sir for his comments and to wind up the session.
Yeah. So actually, I like to thank Madam Nalini Mishra, because you are really an inventor. You get something which appears nothing out of that, very useful and essential, what I consider. It is important, particularly for places where it is remote. This particular knowledge may be of great use. And what is important, then those places also there can be sometimes a massive bleeding. This procedure, this particular, the producing a uterine tamponade can control even a very massive bleeding when we are failing to do many different things actively, right? Like the surgical, immediate surgery is not possible. We are not having a blood transfusion immediately, but then we are having a IV fluid to start with, and to stop or at least to minimize the bleeding, whatever happening for the time being. So in that way, Madam Nalini, your invention should go long way, but then you should pursue like this at many different places, very different. So I consider it is a very nice and wonderful demonstration. So thank you very much. Thank you, madam. It's a very good presentation and demonstration.
Thank you so much.
Thank you, Madam Nalini, Dr. Nalini Mishra, and Chairperson Dr. Pranay Nath sir, for the wonderful video demonstration. From now, I request Dr. Babita Shukla, my co-coordinator, to take on for the session 3.
Good evening, everyone. So our next session is video demonstration of SR cannula by Dr. Samarth Ram, Director HOD. Okay. So I would like to invite our chairpersons for this session, Dr. Deepti Goswami. She has done MD, DCG in cosmetic gynecology. She is secretary of Gangtok Obs and Gynae Society, senior consultant at Dispur Polyclinic and Hospitals. She is an invited faculty at various conferences. Her areas of interest being menopause, infertility, and cosmetic gynecology. So very warm welcome to you, ma'am. Kindly invite and introduce our speaker today.
Hello. Am I audible?
Yes, ma'am, you're audible.
Yeah, I'm really thank you for inviting me as a chairperson. I really feel honored to be chairing this session for Sir Dr. Samarth Ram, sir. And I have no words because I have seen so many videos of him regarding the SR cannula for the PPH management. So he needs no introduction. He's a winner of prestigious senior category Foxy Korean Award. He's received winner. He had received many Foxy Figo Award. KF, he has received gold medal. KF OG President, and also Yuva Foxy Award to prevent severe PPH could bring down the MMR very significantly in Kerala, Tamil Nadu, and Andhra Pradesh. He has many publications. He has published 26 original papers in national and international journals. And once again, I really feel honored, and I invite Sir Dr. H. Samarth Ram to please speak on this important topic. Thank you so much.
Sorry, sir, we couldn't hear you.
Sir, you're not audible. Are you unmuted? Sir, please unmute yourself, please. You're still not audible, sir.
Sir, please check the connection of the headphones once, sir.
Now?
Yes, sir. Yes, sir. Now it's audible.
Yes.
Thank you.
Okay, fine. Thank you. Thank you very much. Good evening. Good evening, chairpersons, and good evening, everybody. Very much thankful to Dr. Sadhana Ji for giving me this opportunity. She's taking me wherever she goes. Along with her, I am in Northeast states now, and which is a very privileged issue for me. And in fact, I'm very much interested in Northeast states MMR. The MMR in Northeast is very high, very high, very high. And everybody, every doctor and Government of India and Foxy has got a responsibility to work seriously to bring down MMR in Northeast states and northern states like Bihar, Uttar Pradesh. The title of the topic I'm presenting, SRPPH suction cannula for the management of atonic postpartum hemorrhage. Indira. Sorry, something wrong here. Ayyo, Indra. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. 50% of the mothers die due to atonic postpartum hemorrhage. Millennium Development Goal aims for reducing MMR 70 per 1 lakh births by the year 2030. In South India, we have almost achieved less than 70 MMR in 4-5 states here. When conservative methods like uterine massage, uterotonic drugs, and balloon tamponade fail, surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Many times, mothers die on roads while being transported to higher medical centers. This is the SRPP suction cannula which I have developed, measures 23 centimeters long. This is the fundal portion, this is the cervical portion, this is the vaginal portion, this is the nipple of the cannula which stays outside and to be connected to a suction machine through tubing. And the mechanism, how it works, this is the atonic flabby uterus bleeding, cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. The uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, and firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction. Here, I am showing a uterus here. Inside uterus, the SR cannula is there and creating powerful negative pressure, and it is resulting in a global constriction of the uterus. You can see the not rugosities, coarse ridges on the entire surface of the uterus, both in the upper and lower segments. For same reason, SR cannula is very effective to stop bleeding from lower uterine segments in case of placenta previa. Achieving closed uterine cavity is the basic and fundamental requirement for the functioning of suction tamponade system. Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. If you see here is a post-abortal uterus, the uterocervical canal length is short and cervix only admits one finger, you have to select a thin cannula. The postpartum uterus here, you have to use a larger diameter cannula. If you use a thin cannula in a postpartum uterus where 10 centimeter dilatation is there, the cervix cannot give properly and effective closed uterine cavity and effective negative pressure cannot be built up and the uterus bleeding do not stop. These are different cannulas are made to match different cervical dilatations and different uterocervical lengths. And these are the cannulas designed for bleeding after vaginal delivery. Thin cannula meant for cervix admitting one finger, and larger diameter cannulas are meant for dilated cervix. And these are the cannulas designed for atonic PPH during cesarean section. Thin cannula meant for cervix admitting one finger, and this larger diameter cannula meant for dilated cervix. And this is the cannula specially designed for bleeding after MTP or vesicular molar extraction, and is also used as a suction tube introducer while doing cesarean section. And when compared to balloon tamponade, in balloon tamponade, the mechanism is totally opposite. Here, the water-filled balloon dilates the uterine cavity, and the distended balloon compresses the bleeding sinusoids to stop bleeding. Different differences between SR cannula, this I will slip. SR cannula application for atonic PPH during vaginal delivery.
Woman bleeding profusely.
Able to see?
Woman bleeding profusely.
Whether the video is working?
Woman bleeding profusely.
Are you able to see video is working? Here it is not working.
No, sir. No, sir.
Woman bleeding profusely.
Only the audio is coming, sir. Video is not.
Woman bleeding profusely. Cannula system should be.
Everything is not working. Videos are what to do?
Woman bleeding.
Yes, sir. Yes, sir. Now it's someone.
Profusely.
No?
So it is stuck at this position.
Woman bleeding profusely.
Whether we'll go to the escape route.
Woman
yes, sir. Now it's working, sir.
Let me see.
Woman bleeding profusely.
Thank you.
Vagina retracted with wide blade spectrum like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be fed bimanually. Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. We can see complete cessation of bleeding within 4 minutes. Retracted well.
Application of negative pressure. A negative pressure of 650 millimeters of mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be created by just switching on the machine. The question is how long to keep the cannula inside the uterus. Usually, the cannula can be removed after 6 to 8 hours. In case of high-risk women, cannula can be kept inside uterus as long as the bleeding expected, even up to 24 hours. Whenever there's a recurrence of bleeding, we can just switch on the machine and the bleeding instantaneously stops. SR cannula application for atonic PPH during cesarean section and in case of placenta previa.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with a thin, long cannula. This is a case of posterior placenta previa with minimal anterior extension on left side. This is the wound stitch technique which I have developed. I don't use green armature forceps. By stretching the wound 4 sides with fingers like this, it is possible to control bleeding, even massive bleeding. This is the another instrument which I have developed called cephalic extractor for floating head.
Fundal pressure. Fundal pressure.
Now placenta separated and removed. Now we apply SR cannula to prevent atonic PPH and lower segment bleeding. As this is an elective section, I am dilating the cervix with my index finger. I am using this thin long cannula as an introducer to the suction tube. Suction tube should be connected to the suction machine. Cannula inserted into the proper position. Cervical portion of the cannula should be in cervical region. Cut edges should be kept together and then back pressure applied. Then negative pressure should be applied. You can see completely contracted and retracted uterus. Blood loss less than 200 ml.
This is a new suction tube introducer we have developed. No need to put fingers inside the vagina. When you introduce this suction tube into the other, automatically the cannula, the suction tube will come out and we can catch it. Foley catheter technique and cannula for lower segment bleeding, this I'll skip. Prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH like PIH, anemia, complicating pregnancy, and accidental hemorrhage.
For prophylactic application, we have to check the suction machine before the delivery itself. for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blade speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, left 2 fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers, tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml.
SR cannula for traumatic PPH. I suggest to apply suction cannula for every case of PPH, whether it is traumatic or atonic. The moment you see excessive bleeding, you need not wait for anything, you need not search for anything. Just insert the cannula and apply negative pressure. Immediately the bleeding stops. In case of traumatic PPH also you can apply. In case of advanced traumatic PPH, some amount of uterine atony is always possible. Cannula corrects this atonic component and reduces bleeding. When negative pressure applied, the cervical tissues get compressed firmly on cannula and stops blood flow in descending cervical vessels, which make the bleeding from the cervical or vaginal tears become minimal. And we can put a white blade speculum under a good source of light. You can see the tears better and you can suture the tears better. If you apply gentle traction on the SR cannula is very effective for transporting the woman with PPH to higher medical center. This is the manual suction pump we use for where there is no power, and during transport in ambulance also we can use this pump. Is equally effective.
Manual suction pump can also be used to create negative pressure inside the uterine cavity. This is useful in places where there is no power and also helps.
So the audio quality in the video is not audible properly, I feel.
Is it?
I think we can sum up now. Then Samartha, you can say directly what you want to say, na?
Yeah.
So
No,
that
I
the
just
people
finish
can
off.
listen to you well. Huh?
See,
Yes.
I'll just see one thing, and
Cannula can be easily removed.
But it is audible to me. It was audible to me. Quite
for me also it is
Probably
audible.
there is some problem on my end. It's okay then.
It is audible.
Yeah.
So I
Dr.
think
Esther,
we can sum up, na? Yes, it is
Now?
very well done. Yes.
Now it is audible.
yeah.
Yes. We have to insert finger between the cannula and the cervix and separate these tissues which was stuck into the holes of the cannula, and we can just remove it. This is how the cannula should be removed after when you want to remove it. And SR cannula is also, the question is somebody is asking whether SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but inversion of uterus can be treated with SR cannula. You have to reposition this uterus into the abdomen and you have to insert the cannula and apply negative pressure. The uterus atony will disappear and the uterus become firm and it will not recur. Cannula is also very effective to stop bleeding even in case of coagulation failure. This is a case of cuvular uterus with coagulation failure, and we have inserted the cannula. We could save the uterus and the woman. Even in COVID positive cases, umpty number of cases with coagulation defect, they have used the SR cannula and they have saved these mothers. These reports are there from Visakhapatnam and also from Thrissur. How to clean the cannula?
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Further, if there is any difficulty, I have given my number here on the cannula. You can call me. I can come to your help. This is the most important information I would like to give for the people of Northeast. This is what the important information I'm giving, sharing now. Under care of government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe preeclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh in the year 2000, July 2018. Oral hydration therapy is nothing but making the antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. Hands-on training workshop was conducted at Chittoor District Hospital, Chittoor. Suction cannulas were provided to all institutions conducting deliveries like PHCs, CHCs, area hospitals, and medical colleges. ANMs and ASHA workers were assigned the job of oral hydration therapy to antenatal mothers to prevent severe preeclampsia. Advised prophylactic application of SR cannula to all women after placental delivery, both in case of vaginal delivery and cesarean section in peripheral centers with suboptimal facilities. I'm showing the results of I'm showing the results 3 months results after application of introducing these two things in the district. You can see here 8,300 and 8,400 deliveries took place in 3 months time in the entire district. We have used 45 sets. They have applied around 1,500 applications of SR cannula taken place within 3 months time, and 1,074 vaginal applications and 429 cesarean applications. You can see here the maternal mortality due to bleeding was 0 here in this 3 months time, and total number of blood transfusions given was 28 for 8,000 and odd deliveries. If you see the comments of the doctors on this performance of this cannula, you can see control is good, but time taken, useful in arresting bleeding, saved 2 pph with PPH, minimum blood loss, very useful in arresting PPH, control is good, and minimum blood loss like this, and useful in arresting PPH, very useful. These are the comments of the doctors from the entire district. Not a single case failed. Cannula never fails in stopping PPH. And again, now recently, day before yesterday, I got this statistics from the district medical officer. These are 5 years results. Now we have completed 5 years of SR cannula application and OHT in Chittoor district here. And you can see 14, 15, 60 deaths have taken place, 60, 60, 47 and all. You can see we have introduced SR cannula and OHT in August 2018. So 19, like this, if you see here, 60 deaths have come down to 9 deaths. Hemorrhagic deaths from 9 deaths, it has come to 0. Last year, for the entire year, not a single death have taken place due to PPH in the entire district. And another important information I would like to share, many people are skeptical about my oral hydration therapy. Here, the entire district is using, and 16 deaths were there, 17, 18. Now, the deaths have come down 10, 10, 4, 3, 1. Last year, for the entire district, for 30,000 deliveries, only 1 PIH related death has taken place. And there were, even when I observed here, even thromboembolic episodes also gradually, there's a trend coming down trend here. The MMR dropped from 88, 94 like this from that day to now 33.3. Now the MMR of the entire district is 33.3. Now entire Kerala, Tamil Nadu, and Andhra Pradesh, 80% of Andhra Pradesh, and many major hospitals in Karnataka are using this SR cannula to prevent and treat PPH. Kerala Federation had included this device in its obstetric protocols to prevent and treat PPH. When you go through the recent statistics of Government of India, you can see this drastic reduction in maternal mortality of Andhra Pradesh, Telangana, and Karnataka. If you see Kerala, you can see here 19, MMR has dropped to 19, and there's a very significant percentage of reduction of maternal mortality here. And in Kerala, MMR dropped to 19, which was never before. This major reduction in MMR in South India is mainly due to introduction of SR cannula and OHT. Humpty number of dissertations are going on at different medical colleges in the country. 3 RCTs are going on at Agra, Chennai, and Cochin. SRPPH suction cannula is a breakthrough innovation to prevent and treat PPH. This is a simple cost-effective, life-saving, and fertility-saving technique. This is a physical method, does not depend on biological factors for its action. No need to maintain cold chain. For the same reason, it does not fail to stop bleeding. Suction cannula system can be organized within 2 minutes time. Bleeding stops within just 2 to 3 minutes. Cannula system works well even in case of coagulation failure. Even with retained products of conception also, the cannula can be applied, bleeding stops. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost effective, autoclavable, reusable instrument. We have to purchase this instrument only once. Helps to reduce maternal mortality due to atonic PPH in low resource settings. Take home message, what I would like to, the take home message here is use SR cannula as a first defense, not as a last resort. But most of the times they purchase the cannula, they keep this in the shelf, and only when they exhaust everything, pitocin, mesergin, carbotation, when they exhaust everything, finally at last they put the cannula. Even that time also cannula stops bleeding. Instead of that, if you use the cannula as a first defense, no need for blood transfusion, no need for tension, no need for transport. Thank you. Thank you very much. Thank you very much. And I cut short my presentation to a major extent to save the time.
Thank you so much, sir, for finishing up in time. I would invite inputs from our chairperson.
Thank you, sir, for your elaborative talk on SR cannula. And you rightly said that SR cannula never fails. And it is a life-saving procedure, and it should be adopted, prophylactically. Thank you for your elaborative video. And it's really high time that Assam also adopts this technique so that we can really drastically reduce our maternal mortality rate, which is quite high in Assam and on the Northeast also. So thank you so much.
Can I say one thing? Yeah,
please.
So I am Dr. Pranay Phukan from Dibrugarh. We are using SR cannula. Today only one person we use it, and we have published our data in our local bulletin for 18 cases. It is good, really good. But I cannot say that it is not failing. One case I remember, I couldn't stop the bleeding, but the rest of the cases of 18, 19 cases, probably they're doing very well.
But one thing,
thank you, Dr. Yeah, it is nice to see you in physics. Yeah.
Thank you. The only reason when the cannula fails is it is improper application. If properly applied, it will not fail. The reason most of the times the failure is one of the holes or two of the holes will stay in vagina when it is not properly going.
Thank you, Dr. Pranay, for bringing up that you are using it, and every instrument has gotten a lot of multiple etiologies there. So that is very important. Thank you, Dr. Samartha, for always being with us, and it's good to have the feedback from others. So thank you, Dr. Deepti, also for your nice comment, and hope it will be finding its way into every labor room of our country. So over to Babita, please.
Yes, ma'am.
Go ahead.
So thank you, speaker and chairpersons, for a wonderful session. Quickly moving forward to our third video session by Dr. Shashi Maheshwari, ma'am. I would like to invite our chairperson for this session, Dr. Pankaj Kumar Barba. Sir is Senior Consultant at Sanjeevani Hospital, Jorat, and past Secretary of Jorat Obs and Gynae Society. Sir, kindly invite our speaker and introduce her and conduct the session. Dr. Pankaj, please. Sir, are you there?
I'm there,
Dr.
but
Pankaj?
I can't. Yes, I'm there.
Sir, kindly introduce madam. Sir. Dr. Pankaj, sir, are you there? So let me do the honors. Madam, Dr. Shashi ma'am is recipient of Wonder Foxy Award 2019, APJ Kalam Appreciation Award 2020, IMA WDW Karambir Award 21, and APJ Excellence Award, Asia GCC Award, for Quality Leisure Healthcare, Rashtriya Gaurav Award. She is National Mentor, Lakshya in association with AIMS Delhi, GOI and WHO. She is member of Practical Obstetric Committee and organized 65 workshops on PPH. all over India. A very warm welcome to you, ma'am.
Thank you so much, Dr. Babita Shukla. Thank you so much for such a generous and kind introduction. And my special and sincere thanks to Dr. Sadhana ma'am every time she gives me the opportunity. Am I audible?
Yes, ma'am.
Yes, ma'am.
My thanks to Dr. Moshbi Ghosh and Babita Shukla ma'am for having me here. So I'm sharing my screen. And my thanks. It's not coming. I'm resharing. Is my screen visible, ma'am?
Yes, ma'am.
Yeah.
Yes,
so my
ma'am.
special thanks to Guwahati, Dibrugarh, Jorhat, Gangtok, and Silchar and Shillong Society too. So let's come to the stepwise devascularization in the management of postpartum hemorrhage. It's a very common picture. You can see here, this is the LSCS area, and we do uterine artery ligation here and here, which is called upper uterine artery ligation, and this one is the lower one. And this is the place for the ligation of anastomosis ovarian and uterine artery. It is the word ovarian artery ligation is a misnomer because ovarian artery is here and we do not ligate this. We here ligate the anastomosis and it is just medial to the insertion of the ovarian ligament. So showing you the video of uterine artery ligation. LSCS scar has been closed. Bladder pushed down, palpate the pulsation of the uterine artery. I take number 1 catgut or number 1 Vicryl for the purpose. It's a round body needle, not a cutting needle. Take 2 centimeters of the myometrium. Come out posteriorly through the uterine musculature. Find out a window in the broad ligament avascular area. Again, pierce from posterior to anterior. And tie the suture. There should be 2 turns in the first knot, which is called the surgical knot. Square the knot and give the sutures. So similarly, we do it on the other side. Now, this is the lower uterine artery ligation, 2 to 3 centimeters below the proximal ligation. Again, the same technique. Take a part of the myometrium from anterior to posterior, come out posteriorly, lift the uterus, find out an avascular window in the broad ligament. Go from posterior to anterior. And same technique, you tie the knot. And needle should be a round body needle. So next I am showing the uterine ovarian anastomosis ligation. This video was made by my colleague, Dr. Soma. So this is the place. Take a part of the myometrium. Again, round body needle. Find a avascular window. Pass the needle from posterior to anterior. The anastomosis has come in between these two middle points. Double turn, see carefully, double turn, squaring of the node, and then applying the suture. Similarly, we do it on the other side. So next, coming to the internal iliac artery ligation. This abdominal aorta divides at the level of L5 into two common iliac arteries. They make an inverted Y here, and then each successive common iliac arteries make another inverted Y. And they divide into external iliac, which is continued as femoral artery below the inguinal ligament, and they give a posterior branch, lateral posteromedial branch, which is the internal iliac artery. So we are concerned about this. We will be talking about inverted Y, and we are concerned about this inverted Y on both the sides. This is an inset picture of this part. This is lateral side, this is medial side. This is the common iliac artery dividing into external iliac and internal iliac. And you see here this internal iliac artery, just after its origin from the common iliac artery, gives its posterior branch, which mainly gives parietal supply to the parietal parts like iliolumbar, lateral sacral, etc. And this is the internal iliac artery. So we have to ligate the anterior division of the internal iliac artery, because this is the branch which supplies mainly the uterus, vagina, vaginal branch, all these. So we have to ligate this. So how to find out this place, I will tell you later. This posterior branch is usually not seen in a pool of blood. So how we will recognize this, I will tell you in next slides. So first, coming to the methodology of internal iliac artery, bilateral ligation results in 85% reduction in pulse pressure, 50% reduction of blood flow. It converts an arterial flow into a venous flow, which facilitates coagulation. Bleeding is reduced. So these are the two things which are very important when we start internal iliac artery ligation. This instrument is mixture forceps, or we also call it right angle forceps, because this bent is at right angle. The tip, there is a tip, but it is not sharp. And there are no, and then second, we have this thread of silk. I make around 15 centimeter length of silk. I use silk and make it double. So after it is around, I take 28 to 30 centimeter, which after become doubling, it becomes around 13 to 15 centimeter. So this is the model which I made for my students to teach how internal iliac artery ligation is to be done. And this is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I'll just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize the internal iliac artery. By this time, the posterior branch is already. This is right angle forceps, also called mixture forceps. It is bent at 90 degrees and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. The vein is below, enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this, because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral to medial. It's always passed from lateral to medial. Gently I will open it. Remember the word lateral to medial. I will get hold of the loop and just gently I will come out. Loop is already preformed. This movement is very, very gentle. Now next step is I will cut this and make 2 threads. Then with 1 thread we make 2 threads. We will not pass right angle forceps twice, because the chances of injury to adjacent structure increases. So look at the technique of applying ligation. Now just
I've
look at the knob.
taken hold of one ligature. I'm not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand and there will be massive bleeding. So I'm giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn. And I've tied it here. Then very gently I applied the second throw. And again very gently I applied the third throw. Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I'll cut this. I'm just cutting.
The same picture I will show you on live video.
This is common.
So this was a case of 26-year-old primary with full-term pregnancy. She was booked initially at one facility, then had ANC at Anganwadi Center. Then she had labor pain on 23rd November. She went into obstructed labor. Then she was taken to another hospital and she had undergone a cesarean section for second stage arrest in morning at 8 a.m. under spinal anesthesia. Then she had an episode of postpartum hemorrhage at 10:15 a.m., which was managed conservatively. Then she had a second episode at 12:30 p.m. and she developed shock. So she was given multiple units of blood transfusion, 4 PRBC, 4 FFP platelets. And in the evening, the patient went into shock again after 11 hours. And that time she was resuscitated and referred to me with 5th ongoing RBC on floor. Her pulse was 146, BP was 10460, but you can see that shock index is higher. And I just did not waste any time in deciding that I need to open the abdomen in this case. When I opened the abdomen, I could see this was a huge broad ligament hematoma posteriorly and also a hematoma on the posterior surface of the uterus, extending from fundus to the colpos, to the vagina. So you see, I performed an obstetric hysterectomy in this case quickly because you know that once a patient has gone into shock, the chances of conservative method decrease and we have to do a radical method. And after hysterectomy, again, there was a small losing in the whole pelvis. So I took a decision of ligating the entire. Now you just follow my picture on the model and see this. This is a hysterectomy, already hysterectomy done, and this is the round ligament pedicle. And below the round ligament pedicle, I've lifted the open peritoneum. We call it retroperitoneum, opening the retroperitoneum. So very slowly, gently, seeing below, I'm cutting this peritoneum, and my direction of movement is parallel to the infundibular pelvic ligament going towards lateral pelvic wall, parallel to the infundibular pelvic ligament and going towards lateral pelvic wall. And my starting point is round ligament pedicle. Now you see there is a loose areolar tissue, which I'm separating only with my fingers. There is no instrument in my hand when I'm separating it. Now you see here, this is the ureter in the medial flap. This is internal iliac artery. This is external iliac artery. And this is the common iliac artery. This is an unedited video. Internal iliac artery, external iliac artery, and this is ureter in the medial flap. Ureter always goes with the medial flap, never comes in your method of operation. It doesn't come in your field of operation. Very nicely, you can see the inverted Y. You do not start doing anything unless you see the inverted Y. This is external iliac, this is internal iliac. Now I'm pressing the external iliac and palpating the femoral pulse. Now again, I am pressing the internal iliac, and now there will be no change in femoral pulse. So I doubly confirm that this medial structure is the internal iliac artery. So this is internal iliac artery. Now you see the mixture forceps is in my hand, and I'm separating the sheath which has enclosed the internal iliac artery and the vein below. And the movement is parallel to the vessel. It is not at all perpendicular to the vessel. And the area, at which place, I've already told you, 3 centimeters below the origin of the artery from common iliac trunk. Now see thin sheath part I'm cutting. I made a place here for passage of right angle forceps. You see here posterior division is not same. So I have to measure the distance with my thumb. Now I'm separating and making a place here so that my right angle forceps can be passed. So this is my right angle forceps. Lateral to medial, I am trying to pass it. You see just below the blue structure is vein. So I passed it nicely. The loop is already beforehand ready. The loop is ready. I've taken hold of the loop and gently I'm pulling this, very gently. So my half work is done. Now it is cut, and with one thread I made two threads because there are two ligatures to be applied on internal iliac artery. Now you have to be very, very gentle. Remember, now I'm separating the threads to see which one is continued with which one. I always do this myself. I do not give in the hand of juniors. And this is an unedited video. It is the real time. Now I've recognized the thread and have given 2 turns. And this is my first knot in place. I'm just kneeling and bending my back and going on the superior surface of the artery, not pulling the artery. Now second knot I'm going to apply. Again, bending my head and back. And this is the third knot. You see here, not even a single moment I pull the artery up. And now I'm cutting it gently. Now the second thread is left, which will be tied 0.5 to 1 centimeter away from the first. You see, you can see the first knot in place. Now I'm applying the second knot. 2 turns in the first knot. With the help of my finger, I'm going to place the knot on the superior surface of the artery. Tight. And then you just see beautifully there is a bulge in between the two ligatures. So they are definitely 0.5 to 1 centimeter away. So never get afraid of ureter. Ureter does not come in way. It goes in the medial flap. So very gently, I am cutting it. While cutting, you have to take care that the artery should not be pulled. And now you see. This is the internal iliac artery along with 2 ligatures. This is external iliac artery. This one external, this is internal with 2 ligatures. This is common iliac artery. So regarding the technique, the passing of right angle forceps or mixed forceps, this one is the right angle clamp from lateral to medial side below the internal iliac artery. And this is wrong because if I pass through this, then it will go and hit the external iliac vein. So these are my own tips, which I'm giving for ligation of internal iliac artery. I made these tips after 22 years of obstetric practice in a hospital where there are 10,000 deliveries per annum. So you open the retroperitoneum from round ligament to infundibular pelvic ligament. You can practice opening the retroperitoneum in gynecological hysterectomies. You know, in gynecological hysterectomies, when you cut the round ligament, you go parallel to the infundibular pelvic ligament and open the retroperitoneum. Tillin says that we should routinely do this and see the ureter, then we should apply clamp on the uterine artery, but we usually do not do it. So it is my advice that you should start doing this in gynecological case, and an experienced surgeon can open it in 20 to 30 seconds. Then this is the method for anterior approach of internal iliac artery ligation. There is one more approach called posterior approach of opening the retroperitoneum. Here we pull the uterus outside and we make a nick 2 centimeter below and 2 centimeter lateral to sacral promontory on both the sides, and then we cut it for 5 to 7 centimeter and open the retroperitoneum. And when we are opening the retroperitoneum, you remember that to keep away all the instruments and only do finger dissection, because this is a loose areolar tissue and there are big vessels of the body, so they should not be injured, and loose areolar tissue very easily gives way. Then the next step is locate the bifurcation. That means you locate the inverted Y, the 2 inverted Ys of the division of common iliac artery into external and internal iliac artery. Then you recognize the internal iliac artery as the medial structure which does not cause any change in femoral pulse. There was a there is a very famous surgeon. Once I asked him, sir, what is the reason behind your success? He told me that Dr. Shashi, मैं किसी स्ट्रक्चर को पहचानता हूं पहले, I recognize the structure, only then I operate the structure. So same thing I am following. You recognize the structure, then you operate on this. Then movement of right angle forceps always from lateral to medial. Then careful knot tying in the cavity. Two ligatures 0.5 to 1 centimeter apart. And last but not the least, always do bilateral internal ligatory ligation, because the literature says that the chances of free laparotomy and morbidity increases if we do unilateral. And this I have seen in my own hospital. So thank you so much.
Thank you so much, ma'am. I think Dr. Pankaj Barwa, sir, are you there? Then please sum up the session. I think sir is not there. So I request our expert panelist for today, Dr. Indranil Datta, sir, kindly sum up this session. I can't see him also.
Yeah, Dr. Indranil is also busy. He's operating a case of
Okay,
PPH.
so Dr. Indrani Roy, ma'am, please sum up this session.
Yeah, I think it was an excellent deliberation, Dr. Sashi. I think you have really demonstrated very well in the video, and it's a very good learning experience. I think all those who have watched this video, I think it is a great learning experience. Thank you so much. And I think it will be very beneficial to all of us. It was an excellent presentation. Thank you.
Thank you so much. You know, every obstetrician, this is high time, every obstetrician should learn doing internal ligatory ligation.
Thank you, Indrani ma'am, for doing the honors. Now, quickly moving towards a panel discussion, I would like to introduce some moderators. Dr. Indrani Roy ma'am from Shillong. Kindly display a CV. Sahiti. So, madam is senior consultant and HOD, Obs and Gynae, Nazareth Hospital, Shillong. She was president SOGS from 2017 to 19, organizing chairperson of East Zone UA Foxy and National UA IS 2022, and member of Breast Committee Foxy from 22 to 24. Our second moderator is Dr. Moshmi. Okay. She is consulted at Tata Main Hospital, Jamshedpur. Manipal, Tata Medical College. She's active member of Jamshedpur Obs and Gynae Society, organized First All Jharkhand Conference, and she's got Foxy Awards, that is Kamini Rao Orator East Zone, Indumati Javeri Award, and Vani Samanta Award. She has contributed to Foxy and ICOG publications. A very warm welcome to you, Dr. Moshmi. We have as expert panelist, Dr. Indranil Datta. Kindly display CV. Sir is East Zonal Coordinator Foxy, Professor and Head Department of Obs and Gynae, IQCT Medical College, Durgapur, Director, GICE Nursing Home, Kalyani. Sir is East Zone Coordinator and a Foxy President. He has published more than 50 articles in various journals. Articles of repute included in PubMed database and Cochrane database, contributed 68 chapters, and he has organized 5 Foxy conferences. A very warm welcome to you, sir. We have as panelists today, Dr. Lata Kharka. She's Associate Professor, Senior Specialist, and Associate Professor at Sikkim Manipal Institute of Medical Sciences, Gangtok. Her area of interest being maternal medicine, high-risk pregnancy related to diabetes and hypertensive disorders. Then we have Dr. Neeta Sharma from Silchar. She is Assistant Professor, Silchar Medical College and Hospital. She has attended several conferences, CMEs, and has got 3 publications to her credit in national journals and 2 in state journals. She's got presentations in regional, journal, and national conferences. And she's trained in RBCW, CISP, and BCBR. A very warm welcome. Next, we have Dr. Vandana Kurmi from Dibrugarh. She's Senior Consultant, Nazareth Hospital. So you have put her CV. Dr. Vandana, yes. She is registrar in Obs and Gynae, Assam Medical College and Hospital, and she is master trainer of comprehensive abortion care. A very warm welcome. Next, we have Dr. Nilottama Saikia. She is senior consultant, Nazrat Hospital, Shillong, executive committee member of Shillong Obs and Gynae Society, guide and co-guide in various DNB theses. She has several publications in index journals and areas of interest being high-risk obstetrics. Next, we have Dr. Kalpana Udupa. She's working as a senior resident in Lakhimpur Medical College and Hospital, Assam. She has won the zonal level quiz on medical disorders in pregnancy conducted by ISOPAV and has one publication to her credit. Then we have Dr. Bornali Pegu from Johrat. She is assistant professor, Department of Obs and Gynae, Johrat Medical College and Hospital. We have Dr. Sirisha Rao Chakravarti. She is consultant gynecologist at Silchar Medical College and Hospital, registrar under Government of Delhi, St. Stephen's Hospital, and associated with Ma THRI, Project Ma THRI, in collaboration with Oxford University, trained in colposcopy. A very warm welcome to you. And finally, we have Dr. Pranabika Mohanto from Johrat. She is assistant professor cum deputy superintendent in JMCH Assam Resource Faculty, NMC Regional Center for Faculty Development. She is secretary of Johrat Obs and Gynae Society, and currently she is working at Johrat Medical College. She has done basic course in biomedical research, ultrasonography, endoscopy, IUI. Her areas of interest being high-risk pregnancy and infertility. So a very warm welcome to our moderators and all the panelists, and I hand over the session to our moderators to conduct this session.
A very good evening to all of you. So at the outset, I would like to thank Sadhana ma'am for this big opportunity today, and I hope all the panelists are there. And our expert panelists, I think Dr. Moshumi, as you have said, Dr. Indranil is not here as of now.
Dr. Indranil has logged in, but he is in a there's a patient of APH operation going on.
So I think our panelists have enough experience,
yeah,
so they can enlighten us. So straight away we will move. We'll have some case discussions on postpartum hemorrhage, and I would request my panelists to be very precise with their answers, so that we can, because we are already running late in time, you can finish in time. So Maushami, would you start the screen share, please? Yeah, so as you all know, we won't go into details of this. You all know PPH, the high, like the percentage, around 30% maternal deaths. And obviously in our part, Northeast, as from before, Shashwati ma'am have also said, the maternal mortality is so high in Northeast, and we really need to do something about it. So I'm really happy that today we are having this discussion. Next slide, please. So we won't go into the definitions of, because I know you are all experts. Yes, Maushmi, next slide. So by definition, you all know what is primary PPH, what is secondary PPH, and the 4 T's, which are the most important thing: tone, trauma, thrombin, tissue. These 4 T's are one of the key factors in identifying what is the cause of postpartum hemorrhage. Next slide, please. So we'll straight away start with the case discussion. The first case. So now the first case here, we have a 38-year-old primary gravida, and she was a case of a DCDA twins, and she conceived after IVF treatment. She was admitted in labor at 35 plus weeks of gestation, and when she came to the labor room, her pervaginal findings at around 9:30, she was fully visced, 3 centimeters dilated, and on doing ARM, the liquor was thick meconium stain. So on ultrasound, she had 2 live fetus. One was cephalic, and the second was a transverse live with a good weight. Fetal weights were good. And as meconium staining plus with a high elderly primary, decision for cesarean section was taken, and LSCS was done at around 10 p.m. and the intraoperative period was very uneventful, and both babies were active. Next slide, please. Now, coming to my first panelist, Dr. Latha, are you there? Is Dr. Latha there?
Dr. Latha has not joined. She has
Okay, so
internet
we can
issues.
move on to Dr. Neeta now. So, Dr. Neeta, I would just like to ask,
Yes.
for this case, what are the preventive measures you want to? What are the things that you anticipate? Because as you know, as an obstetrician, when you practice obstetrics, you know anticipation is a very key factor for your future management. So, what are the preventive measures you would want to take?
Okay, good evening.
Yeah.
So she has a case of multiple pregnancy.
Yeah.
An elderly woman. So in multiple pregnancy, whenever we are going for delivery, be it operative or vaginal delivery, we have to keep blood in hand. That has to be kept ready beforehand. And then we do anticipate PPH in every case of multiple pregnancy. So immediately after delivering the babies, we have to take steps to prevent PPH. So definitely active management of third stage of labor, and look for whether the uterus has contracted or not.
Yes.
And if not, then we'll go for the other measures. Like we've already started oxytocin. If the uterine contraction is not adequate, then we'll go for the other medical management. That is, we can go for carboprost injection. We can go for misoprostol. If uterus is contracted, well and good. If not, then the next step, we may go for the compression sutures.
Yeah, we'll come to that later on. So prophylactically, very, as you say very correctly, I think we should anticipate, because she's a twin pregnancy, so a larger uterus than the normal. So anticipating PPH is very important here. And as you've said very correctly, we should keep blood in hand, cross match, and do an active management of third stage of labor. Okay, so now proceeding to the next. Now, this patient had an uneventful immediate post-operative period. Now around 12 midnight, she's in the post-op ward, and the doctor gets a call from sister that the patient is having bleeding. Her pulse rate is 130, her blood pressure is almost stable, and there is atonic PPH. So lots of blood, she's soaked in blood. So next, my question will be our next panelist, Dr. Bandana. Are you there? Dr. Bandana?
Yes, Pep, I'm there.
Yeah, so what will be your approach to this patient now? Immediately, you were called to the post-operative ward with a pulse rate of tachycardia and hypotension with bleeding.
As the patient's vitals are not stable at present, pulse rate is 130. So I will immediately go for resuscitative measures with first fluid management.
Yes.
And then asked her to get the blood ready. And as the uterus is atonic, we will start the uterotonics with oxytocin first.
Yes. How would you like to give? Any role of tranexamic acid here?
Yes, tranexamic acid is actually second line. We can start with tranexamic acid in this case also, as the vitals are not stable. So uterotonic, so I want to start with at least 40 units in 500 to 1000 ml of the fluid. And after that, tranexamic acid, initially I would like to start with 1 gram IV.
Yes.
And after 30 minutes also, if the blood loss is going on, then I can give another dose of the tranexamic acid also.
So would you like to estimate something on how important is it to estimate the visual blood loss for this patient,
Yes.
no? So that you don't lose time here?
Yes, visual blood loss actually underestimates the actual blood loss. So if I can assess the quantitative measures, such as if we can weigh the soaked gauze and all, and the drap sheets, by that way we can measure the actual estimation actually.
And one of the key factors I think here will be what was her preoperative hemoglobin, you know, because that is the thing we really tend to overlook. The patient whose hemoglobin status is already in the lower side, that patient's response to the PPH will be more, she will go into deterioration more quickly than someone who has a good level of hemoglobin.
Yes.
So I think the next slide, Maushmi, can you display the next slide? So anything else you would want to do after you have given tranexamic acid and oxytocin? Any role of intrauterine balloon tamponade here in this
Still
case?
patient is having blood loss, then we have to go for the intrauterine balloon tamponade, uterine balloon tamponates and all.
Okay, so there is a role of balloon tamponade here, conservative management. So here you have to assess at what point of time you are going to do a conservative management and at what point of time you are going to shift her to OT. Okay, so can I shift to the next panelist? I think Dr. Saikia, are you there?
Yes, I'm there, Dr. Imran.
So now at around, see, from 12 o'clock, we are managing this case. She is bleeding. We have tried our conservative management, but as the time progressing, we are seeing that her tachycardia is increasing, her blood pressure is decreasing. So what will be her next step? What will be your next step now in management?
As the patient is deteriorating now, her pulse rate is increasing and blood pressure is dropping. It suggested that her PPH is continuing. So I'll try to estimate the blood loss if the blood loss is visible outside. And in this case, actually, I'll want to do a PV examination also. If blood clot is collected inside the uterus, I'll try to take out the blood clot, because if blood clots are there inside, uterus will not contract. Along with that, I'll send the coagulation profile, LFT, RFT to the patient. And after evacuating the uterus in the ward, if patient is not, blood loss is not controlling, then I'll consider taking the patient to OT and evacuating the uterus. And there, if balloon tamponade is not put, I'll consider putting balloon tamponade. After that also, if already balloon tamponade was put and patient is deteriorating, her blood pressure is dropping, then I have to consider exploration of the uterine cavity, laparoscopy and exploration.
So we move on to the surgical management. While you can go on, then selectively you can go for selective devascularization. So, and you have to initiate the blood transfusion protocol also. Next slide, please. So I think all of you can remember one thing, the hemostasis, like it is a mnemonic. If you remember, what are the things we as an obstetrician, we should remember? If in case, step by step, like H is asking for help, A is assess all the vitals, the blood loss, estimate the blood loss. You find out the etiology. What is the etiology of the PPH? Then only you can treat accordingly. Then, of course, simultaneously, your oxytocin, massaging the uterus. And if you are in a peripheral hospital, then you can think of those anti-shock garments. Balloon tamponade definitely has a role. And then, of course, B-Lynch and systemic pelvic devascularization. And ultimately, if nothing is responding, you have to take the decision of an hysterectomy. But the most important thing is here the time management. Your time for doing the hysterectomy has to be very specific. If you lose time in doing the conservative measures at one point in time, even if you do an hysterectomy, you might not be able to revive the patient. So I think that factor should be kept in mind. So Moushumi, I think you can take off the next case again. Dr. Moushumi, are you there?
Yeah, thank you, madam.
Yeah.
So good evening, dear panelists. Moving to the second case, which has now become a common scenario in today's era. Gravida 3 para 2 previous cesarean section. This patient was referred by a private practitioner to a referral center with ultrasound report of anterior placenta previa of 36 weeks, 2 days. She's a known case of beta thalassemia minor with hemoglobin of 7 gram%. She's a case of diabetes mellitus. And the ultrasound, which was done at the higher center, showed a single live fetus of fetal weight approximate 2.7 kg, good lighter, and the placental tissue across the myometrium and retroplacental myometrial thickness was less than 1 millimeter, and color flow Doppler showed turbulent lacunar blood flow. This is the picture of the ultrasound. So now moving to the next panelist, Dr. Kalpana Udupa. Can you tell us what is the diagnosis and any apart from this ultrasound with color Doppler, any other additional diagnostic modality would you suggest?
Basically, this considering the history given, this looks like a case of placenta accreta spectrum. To evaluate, already they say that grayscale Doppler is enough for the anterior placenta, but in case of suspicion of percreta in this case, we can go for MRI to see the invasion of the serosa and the adjacent structures. But for all the anterior placenta, MRI is not compulsory. They say for the posterior placenta, MRI is more useful. If the grayscale Doppler is not diagnostically very much helpful, then we can go for further investigation with MRI.
Yeah, very rightly said. So the role of MRI is unclear whether it improves the diagnosis, and it is only suggested for difficult cases or where there is a diagnostic dilemma.
Yeah.
So moving to Dr. Barnali Pegu, how do we now plan for cesarean section in this case? Dr. Barnali? Dr. Barnali, are you there? Or Dr. Sirisha Rao? Dr.
Yes.
Sirisha? Yes.
Yeah, it's Dr. Sirisha here.
Yes, please.
So since we know it is a case of placenta accreta syndrome, so we have to be cautious in planning her cesarean delivery, because we know that we will be overcoming a very difficult situation and she will be planning for hysterectomy. So we have to take proper measures and we have to keep blood in hand. We have to put a wide bore cannula. We have to make aware the anesthetist about the condition, so that proper general anesthesia may be given in case we are planning for a hysterectomy. And we should keep the coagulation profile ready so that we can plan when we go for the hysterectomy, the amount, because once you plan for a hysterectomy, there may be sudden torrential hemorrhage, which is very unpredictable. So we have to take all measures, and we should keep a team. It is a multifaceted team. We need the obstetrician, anesthesiologist. We need the intensivist also, who can put a catheter if required. And then we need a neonatologist, blood bank. Everyone should be ready with the proper decision, because it is a planned case of placenta accreta syndrome. So the critical team, ICU care, intensivist, all should be ready.
Yes, yes, very correctly said. So now planned delivery. So the optimizing the timing of cesarean section is very important, because we have to avoid fetal prematurity and at the same time balance the risk of patient going into labor in the middle of night and creating havoc. So this balance and having a clinical judgment is very important.
It should be a planned cesarean delivery. If it is diagnosed, we should have a planned cesarean delivery, usually in the morning when we get everyone ready with the team.
Very correct, very correct. And they should be cared by a multidisciplinary team, as you have said, who have these expertise in diagnosing these conditions, like a senior obstetrician, senior anesthetist, neonatologist, because we are planning a hysterectomy for this patient. The baby should get the best survival, and blood bank should be alerted. Urologist should be there because there might be a difficult bladder dissection, and critical care team should be alerted because this patient will need a critical care follow-up post-operatively. Steroid cover, very important, because we are doing this cesarean section slightly before term. Correction of anemia, as this patient is a case of beta thalassemia minor. So correction of anemia is important. Blood and blood products should be available. At least 4 units of cross-match blood should be kept in hand. Pre-operative counseling and consent of the patient as well as the family member is important. That massive obstetric hemorrhage is going to happen. Need for multiple blood transfusion. Increased risk of lower urinary tract damage and hysterectomy. So after hysterectomy, there is no further menstruation, and that has to be told in clear language that no further childbirth and no menstruation. And a local availability of level 2 critical care bed is important. Anesthesia, coming to the anesthesia, it is either general anesthesia. Some people also prefer epidural with GA. And the incision, choice of incision again varies. Some surgeons prefer midline vertical incision. Some prefer a transverse incision also. So cesarean hysterectomy with placenta left in situ is the choice after delivery. And these patients need total hysterectomy, because if we do subtotal hysterectomy, the bleeding bed or the placental bed might still continue to bleed, and we will end up doing a hysterectomy and then having a patient who is bleeding, and then we become answerable in such cases. So whatever be the bladder additions, we have to aim at total hysterectomy. And close monitoring of volume status, urine status, and ongoing blood loss is very important. And as you have said, that the ratio of packed RBC, FFP, and platelet should be given in a correct ratio. So can we, as this patient was rightly referred to a higher center, So actually, these patients should be picked up before in the antenatal period and done at a referral center where all these services are available. So Dr. Pranavika Mohanta, can you please tell us how do we go for antenatal diagnosis in these cases? Can we avoid having such cases on the OT table?
In antenatal period, starting in the early trimester, if we have a dating scan where we can see low implantation of the sac, so that we should have a suspicion of that it can be a scar pregnancy implant, like that can be a placenta previa. And routinely, when we do anomaly, also that has to be screened. And if someone is complaining of repeated urinary tract infection or some urinary symptoms, that does happen in some cases of post-cesarean cases where actually there is irritation of our bladder, and or that can give us a clue that if the placenta is anterior and she has those type of problem, we should actually go for more evaluation of the patient. Maybe we can go for MRI also. And placenta previa, the most important thing is like whether it is accreta or whether it's previa. That part actually creates a lot of difference, and we can do that antenatally. Of course, we can do that with good ultrasound, but if it cannot be done with that, then we should refer for MRI so that we can plan her pregnancy, and we should actually counsel those pregnancy patients that her condition is not as usual, a very high risk case that has to be done in a tertiary care center, and ample of bloods are required actually.
Yeah, very rightly said. So all the patients with previous cesarean section and having anterior low-lying placenta should be screened for placenta accreta. And this can be done in the antenatal period. And the risk increases with every cesarean section to the extent of 3%, 11%, 40%, 61%, and 67% after when the increased number of cesarean sections. So even in scenarios in a peripheral setup, when we open the abdomen and see that there is a placenta accreta, then there is, and we are not prepared with blood, we are not prepared with the expertise, then we can always close the abdomen without delivering the baby and referring the patient to a higher center where there are adequate facilities. So for the third case, I'd request Dr. Indrani Roy. Madam, please.
Yeah, so we come to the third case now. So as we all know, we are dealing with all bloody business. Obstetrics is really bloody. So the third case is a 28-year-old. She's a third gravida, para 2, and both her previous deliveries were normal deliveries. And she was admitted in the labor room at 38 weeks of gestation, and she came in active labor. And her pregnancy period, antenatal period, was not very remarkable, and the labor also progressed very well. And she delivered spontaneous delivery. She had a 3.6 kg baby, and there were no perineal tears or a normal uncomplicated delivery. And the labor was also not prolonged. Both first and second stage was completed within 4.5 hours. Placenta was also complete with minimum blood loss. And then she was transferred back to the ward after the proper monitoring. Next slide, please. So now 4 hours following delivery, the patient starts complaining of severe perineal and abdominal pain. She had both perineal pain and abdominal pain, and she was unable to void. And on examination, we find tachycardia with mild hypotension. The uterus was well contracted, and it was felt normally at the level of 24 weeks. But there was very tenderness. The abdomen was very tender on palpation. On pelvic examination, there was no, we've ruled out a vulval hematoma. There was no vulval swelling. Hematoma was ruled out. And on PR examination also, there was nothing as such. Her vitals, her hemoglobin had deteriorated. By that time, her hemoglobin had fallen from 12 gram to 7 point. So we had ordered an urgent ultrasound. Next slide, please. Now, this ultrasound is showing now on the right side, on that next side, there was a 9 to 4 centimeter. It's quite big, 9 to 4 centimeter mass, and the uterus was deviated to the left. So, Dr. Neeta, are you there? So, what was your diagnosis? Are you there?
Case of hematoma. Yes. It's a case of broad ligament hematoma.
So now how are you going to manage this case?
We definitely open up, go for laparotomy, and before that, we need to do proper counseling of her attendants, arrange for blood again. So
like, what are the risk factors for broad ligament hematoma? Usually it is not very common, you know, it's an uncommon like complication.
Yeah, we do not usually anticipate broad ligament
in a vaginal delivery. So what are the things
particularly in a vaginal? The main problem with operating upon a broad ligament hematoma is risk of injuring the ureter. That is the main problem. And so we'll go for exploration, and we'll try to drain the hematoma, secure hemostasis, and then when we close it, we should put a drain. And
so,
if required,
so suppose the hematoma you have opened up and like, you know, you are not finding, you drain the hematoma, but if you don't find a particular bleeding point, then what will be your next step? Can we have the next panelist, please? Dr. Bandana, are you there? Dr. Bandana, are you there?
Yes, ma'am.
Okay, so you don't find a definite bleeder. Suppose you're not finding a specific bleeder in the hematoma when you are draining. What will be your next step then?
After evacuation of the hematoma, I would like to go for uterine artery ligation.
Yeah, okay. Anything else?
And if the hematoma is extending into retroperitoneal regions also, then I would like to go for internal artery ligation also.
Okay. Dr. Saikia, anything you would like to add? Anything else for this patient?
If we don't get a definite bleeder, we cannot leave the patient, so we have to go for internal iliac artery ligation, and along with stepwise devascularization of the uterus also. So internal iliac artery ligation will be required in this case.
Okay, can we move? So many a times, you know, such patients can even land up on an hysterectomy. I think we had seen our previous speakers speak on broad ligament. A definite bleeder many a times cannot be identified, and suppose the patient's condition is like unstable and you have no time, at many a times you might even land up on a hysterectomy. Next slide, please.
Dr. Indranee. Hello, Indranee.
Yes.
Hello.
You want to add anything,
Hello.
Dr. Pranabika?
Actually, I had an experience last 15 to 20 days back only. I had an experience maybe 1 month back. It was a case of obstructed labor, which was operated by my senior resident, and uterine artery was ligated in that case. Bilateral uterine artery was ligated. And middle of the night, actually evening, the case has been done. And at 2 p.m., around 2 p.m., the patient's vitals dropped. Then we came on, and I have done hysterectomy. I have opened the abdomen. But what I have seen is that bilateral broad ligament hematomas were there, which have extended up to the aorta. I have not seen such a big hematoma in my life. Then it has extended up to the aorta, and I could see only blood and this. Then I had to open the posterior peritoneum, and I have drained all the blood, but I cannot see the bleeder. Then I have done hysterectomy with bilateral uterine artery ligation, internal iliac ligation. But one thing I want to tell to this audience that was not a very nice case to do. Actually, I could not. It was in a bed of blood. I had to call my head of the department. After many hours, like maybe 1 hour, we have washed that area with normal saline. After that, only something is visible, that we could see the internal iliac. Before that, we cannot see anything. It was like practically I was in a dilemma that what part to do, what not to do. But it was like washing with saline for pretty long time has given us some scenario that we could ligate bilateral internal iliac, and the patient could be saved.
Yeah, this is the thing, you know, when your field of vision is not clear because you're seeing blood, the hematoma is drained, you don't identify bleeders. So in that scenario, even to do a internal ligation will not be easy. So many a times, these are the difficulties we face in such cases.
And it happened, actually, the cause also, I would like to say that it happened because in obstructive labor, say that my MO has not, she has done in a lower lower segment, like lower incision was given. Lower part of the uterus has been resected. And the second thing is, while giving internal uterine artery ligation, we have to be very much sure that retroperitoneum is not injured. That may be the cause of that broad ligament hematoma, because it was an institutional delivery where a cesarean section was done. Of course, it was a bad case, obstructed labor with edematous growth.
So I think that is a great learning message. Whenever you are doing an obstructed labor, be careful to give the incision high up, don't go down. And even that today we have seen the video of showing bilateral uterine artery ligation, which is demonstrated very nicely how you have to do a bilateral uterine artery ligation. So thank you so much for your inputs, Dr. Pranabika. Dr. Moushami, you can move on to the next case. Dr. Moushami, are you there?
Yes. Actually, I was on mute. So this is the fourth and the final case. We are all getting late. So Gravida 3 para 0 A2. This patient was admitted in active labor at 36 weeks of gestation. It was a cephalic presentation with clear liquor and average size baby. She was in active labor and her blood pressure was normotensive. Investigation now report showed hemoglobin of 9 gram%, serum bilirubin of 7.3, direct bilirubin 5.96, ALT, AST, ALP raised, INR, PT-INR was 1.5, platelet 1.2 lakhs, serology negative, blood sugar within normal limits. So can I request Dr. Kalpana Udupa, what is the possible diagnosis?
Considering that the patient is a normotensive patient with a deranged LFT, probably this might be a case of obstetric cholestasis in this.
But bilirubin level is higher than what we expect or what we see in obstetric cholestasis. So it can be any type of jaundice in pregnancy.
Hepatic.
Any type of jaundice in pregnancy. So what prophylactic steps to be taken to minimize the risk, because she's already in labor now. So what prophylactic steps to be taken to minimize the risk of PPH? Dr. Barnali or Dr. Shirisha Rao? Yeah, Dr. Shirisha.
Since she's a normotensive patient, bilirubin is raised, so we expect the coagulation to be little bit affected because of her deranged liver function test. So we have to be careful regarding the coagulation status of the patient, and we have to get the coagulation profile and keep probably a fresh frozen plasma and blood ready. We can give her vitamin K also.
Yes.
And we can do the active management of the third stage, and maybe carbetocin will be a better option.
Yeah. So this is a case of liver disease in pregnancy, which is a challenging case, and workup should be initiated promptly. As blood pressure is normal, so preeclampsia associated causes are ruled out. This jaundice in pregnancy has high maternal and perinatal mortality. So as you have said, cross-matched blood should be kept in hand. Transfuse fresh frozen plasma prior to delivery and in the peripartum period to correct coagulopathy. Injection vitamin K 10 milligram should be given, and these patients should be preferred for vaginal delivery. Moving to the next panelist, Dr. Pranbika Mahanta. Next scenario. This patient had instrumental delivery with repair of episiotomy. She had a successful vaginal delivery. We have given her fresh frozen plasma of 4 units. We have corrected her blood. Now, after 3 hours, patient is having increasing pallor with tachycardia, blood pressure of 90/60. Uterus was well contracted and with mild vaginal bleeding. Obvious bleeding was less, but patient was going into shock. And on ABG, her hemoglobin showed 4.2 gram%. So how do we manage this case?
So since the 4 T's, among the 4 T's, if you see of PPH, we can see tone is maintained. Then there is mild trauma, actually, in the vaginal mild bleeding. But yes, the thrombin levels, and that has to be seen. and because she had already had liver disease, so that at least we can do BTC, bleeding time and clotting time bedside, and we should decide whether it is because of blood hysteresis or something else. So if it is because of hysteresis, probably we need to have specific component for transfusion. And if we see anything, we can do a bedside ultrasound there. If there is some collection, hematoma or something, then we should have specific treatment for that. But otherwise, it should be, yes, it should be treated by a multidisciplinary team where we can involve the medicine people also if there is no hematoma. If there is hematoma, then of course we have to go for evacuation of that and specific treatment for that. And
yeah, very rightly said. As we all know, the 4 T's of bleeding. So it is always possible that more than one cause can exist in a patient of PPH. So in this case, it is a case of jaundice with where we expect coagulopathy. We have corrected with FFP, we have given blood, but now the trauma aspect is also there. So we have seen that there was a large vaginal wall hematoma opposite to the repaired tear. The tear was missed. So the episiotomy was repaired, and there was another tear which was missed, not seen during episiotomy repair. So this patient, so now how do we repair this? Dr. Bandana. So how do we drain or how do we repair vaginal wall hematoma? Simple steps.
Yes, we have to take her to the OT with proper Paxil and fresh frozen plasma. Everything should be ready. And we have to go for evacuation of the hematoma under anesthesia.
Yeah. So many of times we cannot find a fixed bleeding point in these cases. We have to drain the hematoma, and then layer closure should be done and a drain should be given. A tight vaginal packing can be given. Main is we do in OT because we get adequate light, adequate assistance, and adequate position. So traumatic PPH following vaginal delivery can be due to extension of episiotomy, perineal tear, paraurethral tear, or vaginal lacerations. Hematoma can present as pain or it can present as change in vital signs disproportionate to the amount of blood loss, like the one we had in this case. So those with large or enlarging hematomas require incision and evacuation, and the involved area should be irrigated and bleeding vessels ligated. In patients with diffuse oozing, a layered closure will help us to secure hemostasis and eliminate dead space. So to summing up our panel, PPH can happen without warning to any patient whom we anticipate bleeding because of high risk causes, or we do not anticipate any bleeding. PPH can happen in that scenario also. So the strategy is to stay prepared to handle hemorrhagic emergencies. So protocols and algorithms of how to manage such cases should be displayed in labor room, and regular PPH drills should be done in the labor room to coordinate the teamwork between the doctors and the sisters. Maintaining obstetric hemorrhagic carts and boxes is very important. PPH warrants sure and swift obstetric judgment. Increasing experience and will to learn from each experience serves only to sharpen one's alertness during this stage. So saving the life of the one who gives birth to a new life. So every mother counts. Yeah, thank you for the opportunity to moderate the panel.
Thank you so much. It was a nice discussion.
Thank you to all the panelists. I think all the panelists have done an excellent job.
Thank you so much.
Yeah. So it was nice.
Thank you. We had
hearing
nice
from
time.
all of you.
Do we have the expert panelist, Dr. Indranil? He said he has logged in, but if he can hear us.
Neil is busy. So thank you. And this was a great share. What is Dr. Prabhanikana? So that the very, very right, how the small things can land up into the big thing, like simple thing that the lower the head, then higher the incision at right time, and just We had yesterday wonderful like e-cesarean workshop. So this is the simple protocol, and how like Pramanika, this is Indrani for all to you carry forward, that the standardization of cesarean section technique. It is actually a public health issue. Then how to like teach our young resident that how to do cesarean in second stage difficult situation, and the standardized, like nothing going on their own ways. So that led to such a life threatening that like by all your effort and by a little bit sheer luck that you could save the patient, because these are the situations which can be very dicey. So great input, because we learned so much from your experience actually, that how your courage and your conviction make it, and what are the gaps in our system that we actually don't want to have the criticality. We really want to have safe delivery, safe cesarean section. We have a good risk assessment, and what are the gaps nationwide at the regional level and the local level. So always a great learning to listen to all panel, because that your sharing of experience actually make us wiser and how to take the things ahead. So thank you Indrani, you came despite your travel, and about how wonderfully you were moderated. So thank you Indrani, you are like you like accepted our request at a very short notice. And
thank you so much, ma'am, and I really wish all the best for you, and really prayers with you.
Thank you. Your prayers will be fruitful, because always the heartfelt prayers are listened. So we look forward to really working for many gaps in our system, and how to like make confident, make confident every OB-GYN, that they are confident, they are dealing with that. It is interesting, it is a something very satisfying branch where we could have a real result in form of a good health. So thank you very much. Thank you once again. Thank you again, all office bearers and members, and for making this happen, and that we are together. Thank you very much.
So do we need an official vote of thanks, ma'am? Okay,
yes,
going for our official vote of thanks. It was indeed a wonderful webinar. I'm really thankful to our chief guest, Dr. Gokul Das, our guests of honor, Professor Saswati Shanyal Chaudhary and Dr. Arun Barwa. So thank you for your words, pearls of wisdom. We are really thankful you took out time from your busy schedule and you shared with us. I'm thankful to our speaker, and she's also a key organizer, Dr. Sadhana Gupta ma'am. Then we have 3 video presentations by Dr. Nalini Mishra, Dr. Samarth Ram and Dr. Shashi Kabra. We are really thankful to them for sharing their videos with us and sharing knowledge to these societies. It will be really helpful in future managing of PPH cases. I'm thankful to all our chairpersons, Dr. Pranay, Dr. Manjima Ganguly, Dr. Pranay Nath, Dr. Deepthi Goswami, and Dr. Pankaj Kumar Barwa for taking out time and conducting all the sessions so very smoothly. Our sincerest thanks to our moderators, Dr. Indrani Roy and Dr. Mosmi Das Ghosh for conducting the panel so beautifully. And of course, to all our panelists, Dr. Lata, Dr. Neeta Sharma, Dr. Vandana, Dr. Nilotparma, Dr. Kalpana, Dr. Bornali, Dr. Sirisha, and Dr. Pranabika Mahanto for giving such wise inputs. Of course, a big thanks to our IT team, which who have conducted this webinar so very smoothly. And of course, all of you must remember our only deserving Foxy presidential candidate for the year 2023 is Dr. Sadhana Gupta ma'am. I really expect all of you will talk to your friends and all other society members that we should all vote for Sadhana ma'am. We really look forward to see her at the highest post of Foxy.